We are recording. So today we are going to cover prosthetics and orthotics. Those terms are not synonymous. That's probably the biggest thing that I can say that I see people making a mistake here when we're talking about these, right? What is the difference between, well, first of all, what is an orthotic? When you think orthotic, what word comes to mind? Yeah, device used to help and assist, not artificial yet. Brace. When I think orthotic, I think brace. Can change the insertion point. Yeah, so that's what I'm just trying to give you an easy way to kind of differentiate between prosthetic and orthotic. When I think orthotic, I think something to brace the body, provide support to the body, right? It doesn't have to be a traditional brace, but even a shoe insert is a brace, a support for the body, right? Versus prosthetic, what is a prosthetic? Yeah, fake limb, right? It is a replacement part, right? This is where you take your car to the mechanic and your alternator's out, and instead of giving you a General Motor or a new General Motors alternator, they go and get a Pep Boys version. Right? That's or a prosthetic is a replacement part, or maybe they put a hamster on a wheel in. That would be a really good prosthetic for an alternator on your car. The hamster just running around a circle. So that's kind of the way I think of these when I'm looking at questions. Because you need to, first of all, when you get a question on the boards about these, they look very similar, but you have to make sure you understand whether they're asking about orthotics or whether we're asking about prosthetics. Some of the things we're going to deal with, both of them, are very similar, right? We're going to be talking about areas of pressure, areas of sensitive pressure, areas of breakdown. All of that can happen on both of them, right? But a ankle foot orthosis is not the same as a prosthetic limb. And when you're talking prosthetics, even what I have in my neck is considered a prosthetic, right? My two plates in the front and the back of my neck, they're technically prosthetics because they were replacements for body parts. If you get a knee replacement, theoretically, you're giving a prosthetic. Yeah, lumbar orthosis, yeah, we get bored with those really quick. We're going to talk a little bit about that kind of stuff in a little bit here. So we're going to start with orthoses today. So orthosis is this is the definition according to your book. An external appliance worn to restrict or assist with motion or to transfer load from one area to another. It is designed to be fitted to the body and achieve one or more of the following goals. Brace or bracing is a term used in the past. Control biomechanical alignment. Correct or accommodate deformity, protect and support an injury. So those are kind of what an orthotic is going to do in general. So why do we do orthotics? Well, we may do it to relieve pain, right? Jaira just mentioned lumbar orthoses. We can prescribe a lumbar orthosis if the patient has low back pain. And sometimes just putting that lumbar orthosis on relieves pain. You'll be amazed at how many patients I've seen in outpatient that tell me when I wear my belt, my back pain is better. Why do you think that is? Not to wear it too much. Yeah, you're exactly right. Why do you think sometimes with patients that have low back pain, if they put a belt on, they feel better? Well, think about it. That's not very, Jaira, if you think about it, a belt's not that far from a lumbar orthosis, is it? Right? And there are actually things called SI belts that we give to, especially sometimes to women that have post-pregnancy and stuff like that, where their SI joints may be a little unstable from the parasite that was growing in them. And it helps stabilize that for a little bit enough to relieve some of that pain. So yeah, relieve pain is a big one. Limit motion is probably the most common reason we give orthoses, right? Maybe immobilization after surgery or trauma, right? You tear an ACL, We may put you in an immobilizer so that your tibia doesn't anteriorly translocate. Compression fracture management. Jara mentioned those lumbar orthosis. A lot of times those will get those for compression fractures. Kinesthetic reminder. If we have a patient that we're telling, don't bend over, don't bend over, don't bend over, we may put them in an orthosis that stops them from bending over. No slouching, exactly, right? When I'm gaming, I wear a figure 8 brace because I find that the more and more I game, the more and more I start looking like Gollum, right? Precious, my birthday present. I start looking more and more like Gollum sitting in the dark playing video games. So I have a figure 8 brace that pulls my shoulders back while I'm gaming. And what's funny is, once I pull my shoulders back, guess what happens to my posture? Suddenly my posture is upright. It's weird how that gives me that kinesthetic reminder not to slouch and be kind of lazy. Correct deformity. If the patient has scoliosis, definitely need something to correct deformity. And we're going to talk briefly about scoliosis, just because I want to make sure we beat that into you again, because I don't know how far Dr. Sokel went into that. To relieve symptoms of a disease caused by supporting or assisting the muscular nerve system. To reduce axial loading, right? Axial meaning head. If I've got a compression fracture of my cervical vertebrae, I need to take weight off. If I don't take weight off, I'm going to get worse of a compression fracture. And just to improve function, right? If I'm missing dorsiflexion, I may need an orthotic to help me get dorsiflexed. Whereas the old guy I saw on Friday for a patient or for another PT, my doctor said I'm having problems with horsiflexion. Horsiflexion? Yeah, he's having problems with horsiflexion. And I said, nay, that's the wrong term. So recommending orthotics. Well, we have to see if it's assisting in improving movement, reducing muscle tone, protect against injury, provide proprioceptive feedback, and provide rest. All orthotics should have a wear schedule. That wear schedule is when the patient should have that orthotic on and when the patient should not have the orthotic on. A wear schedule may just say from a doctor, if you ask the doctor for a wear schedule, they may put something like this. Any time OOB. What does that mean? Well, yeah, anytime they're out of the bed. That means that orthotic's got to be on. Patient gets up to go pee. They've got to put the orthotic on. Patient gets up to sit out in a chair. They've got to put the orthotic on, right? They may put during mobilization. So that means if the patient's sitting down outside of bed, they don't necessarily have to have their orthotic on. But the minute they get up to walk, or the minute they get up to go pee, or the minute they get up to go out and talk to the nurse, that orthotic has to go on. So we need that wear schedule, which is really important. Now, the wear schedule may be determined by a couple of different people. Let's see. Mr. McKeever's having a good spelling day. So who may determine the wear schedule? I just said one of them. The doctor, right? So the MD may describe it. Now, there is also the likelihood that you may ask a doctor what a wear schedule is, and you know what they might say? I have no idea. So then it's going to go to the PT, right? The PT may decide the wear schedule. The other person that may be involved is the orthotist. And this is something you guys can get into if you're interested. So once you guys are graduated and are licensed as a PTA, you can go for additional schooling to be a prosthetist and orthotist. And then you become the specialty person with setting up prosthetics and orthotics. I want to say it's another 2 years, but don't quote me on it. I think it may only be like 18 months. But it's actually a pretty cool career. PTs become it, OTs, OTAs, PTAs. But you basically become specialized in getting these prosthetics and orthotics set up to the point that you may be involved with surgeries. A lot of one of my friends that I have that's an OT runs one of the big the big prosthetic P&Os companies here in town. And the first time I met her was in the ER working with the doc, because she needed somebody to come down and do traction on a patient while she put on a halo. And so they volunteered me to go for some unknown reason. I don't remember what it was, but you can become an orthotist. So the orthotist can just help you decide the wear schedule. Nursing, I can guarantee if you ask nursing what the wear schedule is, they're going to say they have no idea what you're talking about. Where does that wear schedule need to be indicated for a patient? In their what? Yeah, in their notes, right? So let's say that you're going in to see a patient and the DO says, so DO, orthotic doctor, right? Hey, I need them to be putting that TLSO, the thoracolumbar orthosis on every time they're out of bed. What should you do? What should you ask the doctor to do? Hey, can you pretty please stick a little note on their file for me? That way it's in there for them, right? And then when we do our documentation, right, where would we put that? Because that's not a subjective reporting. Put in plan. Okay. Yep, that would be fair, actually. I tend to put it in an O because I take what a doctor says as a very specific order. And technically, that's what objective is, right? You could put it in P as well. Absolutely, Jara. I never thought of it that way, but that actually kind of makes sense too. I just always, it's one of the things I first put on is, you know, in my O, I may put MD has requested patient wear TLSO at all times out of bed, requested MD to put in notes. And then I'm going to tell my PT on top of that, right? When we're thinking about this, can we train a patient how to use an orthotic, or does it have to be a PT? Yeah, we can. We do most of it. Honestly, most of the time, what the PT with orthotics and with assisted devices, most of the PTs will go give them this, and they'll put it in their notes, and your job is to teach them how to use it. So I mean, and I think partially it is because a lot of PTs don't have specifics on how to teach patients how to do it. It's kind of like wheelchairs. The one year we did an integrated wheelchair lab with UNLV, and the DPT students had no idea how to measure for a wheelchair. But we do. So it's kind of one of those things. That's one of the things that is kind of nice to us. So when we look at an orthotic device, we have to think about the weight of the orthotic device, right? If I've got little Millie and she's, you know, 5'0", 89 pounds, and I give her something like a Jewett brace. I know that the term doesn't make sense to you yet, or I give her a really, really rigid frame brace that's made of metal, and I throw that on her. Could that prevent her from moving as much? I give her a 60-pound brace. Yeah, right. She may not even be able to lift it to put it on. So we have to think about that. We also think of the adjustability. Just like wheelchairs, what do you think is going to happen to a patient once they get a brace? They're going to gain weight. It almost always happens because they just stop doing as much. So we have to have the ability to adjust it, right? If I make a custom ankle foot orthosis and I make it out of carbon fiber, which we can actually, we can order carbon fiber braces, they're super expensive. And then if it's not able to be adjusted, well, then we just blew whatever the budget was for that brace. What are the functional uses? What are the cosmoses with it? How does it work with clothing and stuff like that? What's the cost? Because we have cheapy braces and we have expensive braces. Durability with regards to cost. As durability goes up, price goes up. As weight goes down, price goes up. Right? It's the same thing with, braces and even prosthetics are a lot like sports cars. The more ability that sports car has, the greater the price. The lighter the sports car is, typically the greater the price. Same thing with these. May not be as durable either, but ability to fix various sizes of patients. We have universal braces and we have custom braces. You'll hear these terms donning and doffing very frequently. What does don and doff mean? Yeah, on and off. I don't know why we don't say putting on and off like that, but we use the term donning and doffing. They had trouble donning their brace today. Anyway, those are the common terms. It is fancy, right? I feel like I should have a cup of tea. Okay, the good old chap had difficulty donning his brace today. Accessibility to stuff like trach sites, peg tubes, other drains, right? If I've got a TLSO and I've got a JP drain in my spine, I have to have a way to get that cord out in order for the drain to function normally, right? If I've got a patient that's got a breathing tube and I put them in a cervical collar, that cervical collar better have an opening for the breathing tube. Surgical sites, right? If the patient's got maybe needs to have a brace after a total knee replacement, we need to have access to the surgery site so we can do wound care. And then the big one thing is it able to aerate, allow air into it so the skin doesn't macerate, gets soft and gooey, right? The other thing is the longer they wear the brace, what's the side effect of wearing a brace for a long time? What do you think that brace smells like after a while? Yeah, really, really bad, right? Do you ever see the Febreze commercial where the lady's talking about the funk? Well, the funk is in braces, right? So patients have to know how to clean it. Because I guarantee, not the good kind of funk either, yeah. I guarantee that, patients don't clean the braces. They don't. It's funny, we have a neck brace back on campus that one of the students got her makeup all over. And now everyone freaks out every time they look at it. They're like, is that blood? I'm like, no, it's makeup and the student didn't clean up afterwards. Same thing. So if that stuff gets in that brace, right? Now it's clean, but it's stained the brace. It was kind of like Donald Trump makeup. It stained it kind of orange. Now that's in the brace, a lot of times you can't get it out, right? But if you have stuff like that where the makeup's getting in that brace, that then blocks the aeration, which means the skin is more likely to macerate from moisture and sweat. So we talked about durations determined by the individual situation. In situations where instability is not an issue, recommend the use of the orthosis until the patient can tolerate discomfort without the orthosis. So what this is saying is, if we don't need a ton of stability, like maybe you twist your ankle and you want to put on a brace because for the week or so that you want to make sure that it's a little bit more stable and it doesn't hurt as much. Great, put that brace on. But as soon as you can, get rid of that brace. Because what happens if you wear a brace long term? Yeah, promotes muscle atrophy. Exactly, right? And then let's say I do that. I sprain my ankle, so I wear an ankle brace long term. What's that mean the next time I don't wear that brace and I'm walking? I'm likely to re-sprain my ankle, right? Because now those muscles don't know how to function as effectively by themselves. And so, I get up in the middle of the night to go to the bathroom, probably don't have my brace on. I find a piece of Lego, step on that piece of Lego, roll my ankle, and now I've got a worse injury. When used for stabilization after surgery or acute fractures, typically the time frame is 6 to 12 weeks. So when I'm talking to my patients and they ask me, well, how long do I have to wear this brace? I usually say, well, it's usually 6 to 12 weeks, but unfortunately that's up to your doctor. So could they be wearing that brace longer than 6 to 12 weeks? Sure could. Could that be a lifelong brace? Sure could. But it's up to the doc to decide when we stop using the brace. It may decrease pain. I don't, the book says this. The book says increase strength. I don't like specifically saying that. I would rather say improve or increase stability, because you're not really improving strength. You're more just providing stability. Improve function, increase proprioception, posture, correction of spinal curves, protects against spinal instability, minimize comps, and assist in the healing of ligaments and bones. That's kind of what the orthoses are designed for. What are some drawbacks? Discomfort, pain, skin breakdown, nerve compression. All of these come along the way. This one down here, I think Jaira made the comment about this. This is probably the one that I worry the most about. Psychological and physical dependency. Because, you know, two things I worry about most. This here, psychological and physical dependency, and then also them just not wearing the brace. So it's this really delicate balance. Because you'll have people that just aren't wearing the brace. They come in for therapy and you're like, Joe, where is your knee brace? Oh, well, you know, I forgot it again. And then you'll have the opposite, where you'll have Mary coming in and they're like, Mary, I told you don't need your brace anymore. And she's like, it felt a little shaky today, so I put it on. Right? And again, the longer they wear it, the worse it is. Patient compliance is just poor, just like anything else, right? What's the number one reason patients don't do their home exercise program? Patient compliance is poor. What's the number one reason patients don't show up for appointments? Patient compliance is poor, right? That's just a general trend, right? So we can improve function. Save energy is probably one of the big ones I think of, especially when I'm dealing with long-term bracing or long-term supports. Increase endurance. The main goal of the function is to increase function without creating dysfunction. That's the main point of an orthotic. So we can provide stability, right? We're going to look at these to figure out why we might use it, right? Correlate the findings of tests and measures, correlate with the patient personally and impact the device has on the patient, right? Correct deformities, prevent the development of the deformity can be also there. Orthosis, just like everything else, the main important, and this I'm going to stress, like I've stressed about 5 different things. This part here, orthosis is only one component of the treatment. That should not be the only reason they're coming to physical therapy, is just to get an orthotic. I tell that doc sat a lot in the hospital when I was the DOR, because they would just order an orthotic consult. So they'd send down PT for orthotic consult. If they're sending down for an orthotic consult, should that patient also have PT? Right? If we're going to put them in a brace, they should have PT. So it's kind of important that I tell my docs that. I'll say, look, I appreciate you want me to look for the right brace for them, but really, if they're getting a brace, they're going to need some PT with that brace. So can you put a PT order in too? Most of them think that just putting that orthotic consult in is enough for a PT order, right? But somewhere in their order has to be that magical word, PTA208, evaluate and treat. Do you guys see, any of you see that when you're out in the field? That's like the generic PT order coming from the doctor. PTA208, evaluate and treat, right? Or worse, they'll just send it over for OT and say, OT, evaluate and treat, and they're supposed to be seeing PT. So PT is going to come in and evaluate the range of motion, manual muscle testing, work with an orthotist to determine the best orthotic need, prescribe the orthotic, right? It may take time for the orthotic, may take time to come in. Then we have to evaluate if they're actually using that orthotic correctly, and maybe contact the orthotist if it's a custom one, change. If it's not a custom one, we may make changes to it. And then continue to teach and train the patient on proper donning and doffing, right? Again, this is very much like everything else. The patient's got to get some STDs here, some show tell do's, right? So you got to show them how to put it on. So you're going to lay on your back, you're going to roll it under, you're going to strap it across, and you're going to roll out of bed. Excuse me. And then you're going to ask them, okay, tell me what I just did. Okay, so we're going to do this, we're going to do that. Okay, now I want you to do it. You've got to get them doing their own bracing, because there's going to be a time at some point where they have to put that brace on and no one's around. So we have a couple different terms. I know it says types up here, but I probably shouldn't use the term types. This probably should be terms for orthoses. Is a better term, better term. Right, so terms for orthoses. The two main types we have are temporary or permanent. If it's temporary, it's only gonna be on for a short period of time. If it's permanent, it's permanent. I mean, shouldn't have to explain that. And then the other thing is either a static or a dynamic orthosis. Static orthosis is gonna be fixed, not gonna allow any movement, and is going to keep them kind of locked in place. When I think of a static orthosis, I think of a TLSO, thoracolumbar stabilization orthotic, right? They're not going to get a lot of movement with that. They're kind of stuck in that, right? But maybe for the elbow, I might have a Bledsoe brace. And a Bledsoe brace is a dynamic orthotic. It has a dial on it that can limit my range of motion. So maybe if I've had some surgery on my elbow or something like that, I can wear that brace and limit them to 45. Bledsoe, Bledsoe. Where I'm going to have a couple of pictures coming up shortly, so don't totally freak out yet. And Bledsoe is just a company, just to let you know. It's just, so you'll find real quick that even though it may not be made by Bledsoe, it's called a Bledsoe brace because Bledsoe makes them. If that makes sense. Well, Bledsoe actually comes from football player because his family develops braces. His family company makes braces. But, you know, it's just like a Philadelphia collar. Philadelphia collar is what we call those soft collars for patients that have cervical injuries. Most of them aren't true. Philadelphia is a brand. Aspen is another one. Put an Aspen collar on them. Usually not an Aspen collar, but just because it's kind of like Tylenol, right? We don't talk, go get me some acetaminophen. We say, go get me some Tylenol, even though it may be Walmart brand, right? That's kind of the idea with a lot of braces. So orthosis can be constructed from metal, plastic, leather, synthetic fabrics, or any combination. It can be constructed from wood. I've seen some really, really cool ankle foot orthoses that are made of like balsa wood. And the one that I saw was the best was there was one made of cedar. Sling would be considered an orthosis. Yep. That would technically be considered an orthosis because it's going to limit motion, right? Wrist braces are going to be considered orthoses. Those, what are those called? The carpal tunnel braces. Those are going to be orthoses. But as to like saying, this one patient that her son had a ankle foot orthosis and she did woodwork. And so she took the plastic brace that we gave him, took it home and made one out of cedar. It was like beautifully designed too. But why do you think she made it out of cedar? Because the kid's got a funk. And BPA free, exactly that too. Well, no, her thought process was it was something she could make for him. First of all, that was kind of cool for mom to do, right? But at the same time, the kid's wearing it and it's got a cedar smell. So it doesn't get as funky, right? I don't know if you guys have this, but for my dress shoes, I have little cedar inserts I put in my dress shoes that keep my shoes from smelling kind of funky. Same idea there. She thought, well, if they do it for our shoes, why can't we do it for that? The orthotist checked it, and orthotist was like, you made this better than our plastic one. Thermoplastics are the most common in the orthotic industry. Thermoplastics, what is a thermoplastic? What do you think that means? What do you think thermoplastic means? A plastic that can be molded by heat. Yeah, it's That's all it is, right? Even something such as a finger cock-up splint for somebody that maybe has trigger finger. It's an orthotic, and we can make those. We don't do that as much. When I went through school, we actually had to be trained on how to make orthotics. Like we actually were taught how to make TLSOs, we were taught how to make AFOs, like cheapy ones, not like fancy schmancy ones. But with thermoplastics, we don't do that as much anymore because PTAs aren't as involved in making the splints. If you work in a hand clinic though, guess what? You're gonna be making splints a lot. So you gotta get good. Now they make these really, really fancy pans for heating the thermoplastic up, but you know works just as well? Hydrocollator. A lot of clinics will just throw the plastic in the back of the hydrocollator and let it sit in there for about 20 or 30 minutes and then pull it out and mold the plastic. It's kind of funny. But instead they'll sell you this big pan that kind of looks like, you know, those big pans of water that they have when you have like a catered event that they put the pan of food over and the water keeps everything heated. It's kind of what a thermoplastic pan looks like. It's not heated by candles though, usually. So thermosetting materials, yeah, sous vide, exactly. Thermosetting materials can be molded into a permanent shape after heating, right? They're usually used in conjunction with vacuum forming over a molded plaster model. So a lot of times when we're getting a more permanent orthotic, they're going to take a plaster measurement of the patient, so design everything around them, build the orthotic around that plaster, and then set it to the patient. The low temperature thermoplastics are the more common ones you'll see in the clinic. These are ones that can be heated and molded with hot water and cut by scissors. The thermosetting materials, once they're set, they're pretty much done. So this is why you want to make sure they go to a good orthotist to get one of those. And then the really, really high temperature ones are the ones that are designed for people like runners and athletes because they have a high rigidity and are good for high stress. They don't break as much. Metals can be used, stainless steel, aluminum, right? But understand when as soon as we start adding metal to something, we start adding weight. Even though metal is going to provide a lot of stability, it adds weight. But we can combo it. We can use metal with thermoplastics or metal with padding and reduce some of that weight if we need to. So why do we select the great materials? Well, we got to figure out what we're doing. What do we want strength-wise? What do we want stiffness-wise? And what do we want durability-wise? If we have a patient that is only going to be wearing a brace for 3 weeks, do we have to order a custom orthotic for that patient? What do you think? No, probably not. We can probably go get an off-the-shelf orthotic and adjust it, right? Most off-the-shelf orthotics, we can do some adjustment. Now, what if we have an 800-pound patient and they're only going to be wearing it for 3 weeks? Now we might have to get a custom orthotic because we don't have, Jaira, you dealt with a lot of, abdominal braces and stuff like that. Did you have any braces in stock for an 800-pound patient? Yeah, right. So that we have to get a custom for. So there are reasons why we might get it. It's not necessarily the duration for that. Durability is a big one, right? If I've got, I'm designing because I had one once where this was a offensive lineman. And he had a congenital nerve damage where he had lost dorsiflexion in his right foot. His tibialis anterior basically wasted away. And we were designing an AFO for him. Now, if I just gave him an off-the-shelf kind of plastic cheapy AFO and he went out and played football with it, what do you think is going to happen to that AFO every practice? It's going to break. Yeah, right? So we got him to a custom orthotist who built a lot of his out of titanium and carbon fiber. And he was able to play 2 football seasons before it broke. And why did it break? Because he played baseball with it. Don't ask. He evidently took it off and was hitting baseballs with it to show how strong it was. Jerry said about compliance. These are the things we deal with. They're like, how did it break? Well, he was like, well, on Friday night we were out and I was telling him how cool this brace was you guys made me and how strong it was. And I said, watch this. Go ahead and pitch a fastball at me. I can hit a baseball with it. Those are the things you can't prepare for. Density, the greater the amount of thickness, the material, the more rigid and durable, the more weight. Corrosion resistant. We used to make stuff out of iron, as we call it back home, or iron if you're out here. Iron from where I'm from. We used to make stuff out of iron. Why do you think we don't make stuff out of iron anymore? Number one, weight. What happens when sweat gets on it? Yeah, rust, right? It corrodes. So we don't want to put a brace on a patient that's got rust on it. I'm just saying. And how easy is it to fabricate? What are we looking for on this brace? So we're going to talk about kind of some basic principles of orthotic design, a 3-point system, kinesthetic reminder, and intercavity pressure, right? The 3-point system is typically when we're going to provide a patient with 3 points of interactive contact. So I have point 1, point 2, and a point 3. Your typical low back brace is very much like this. There's going to be a point of contact typically about the breastbone, point of contact about the ASIS, and then the low back. That provides a nice 3-point contact for the patient. That provides them with that kinesthetic reminder. And we also have to be thinking about how much pressure we're putting on the patient. Because, and Jared will tell you, because I'm going to keep using him because he talked about it. When you tell a patient to put a brace on for the first time, they do one of two things. They either put it on so loose that it falls off, or they put it on so tight that they end up giving themselves a pressure injury. There is no in between. So we have to be aware that if they've got a lumbar fracture and they're putting the TLSO on and they crank that in there, all that cavity pressure is here now. A lot of times I've seen this in the clinic where the first time I put them in the brace, they have to poop. Because you get that brace on them and it squeezes and all the stomach says, hey, thanks for the help. It happens in the hospital a lot. You're getting them out of bed, you're putting that brace on, you squeeze on, they're like, I have to poop now. Or they have to pee because you got that intercavity pressure kind of working. Equilibrium principle. Oh my gosh, this sounds like something we talked about back in mathematics. Do you remember that? Sum of all forces created must be equal. This comes into these braces. What does this mean? Well, if I've got a brace with a 3-point system, I've got 2 points in the front and 2 points in the back. If this is pushing with 5 newtons of force, and this is pushing with 5 newtons of force, and this is only pushing with 2 newtons of force, I've got extra force going that way. And it's going to be an unstable brace. So all these forces have to work out to be equal in order for this brace to work. If it's not that way, the brace will not function fully, right? So that means if I have a combination of 5 newtons, I got to have 10 newtons going that way, so the forces equate out. That's a difficult task to get, right? So you have to understand that the forces have to be 0. This is a question you will get on your boards. It'll say in a 3-point system, the sum of all forces on that brace must be equal to 0. In a 2-point system, if you have a brace with only 2 points of contact, what do you think the sum of all forces have to be? 0. Because let's say I've got a brace that's putting a ton of force on the front of my chest and a low amount of force on my low back. I'm going to walk around like this. All right, so that means I'm going to be way off. I'm going to be pushing my belly out and walking down the hall looking like the Kool-Aid man. Oh, yeah. Oh, wait, no, it's Randy Macho Man Savage. Close enough. So the primary force is located at the point where movement is either inhibited or facilitated, depending upon the function of orthosis. So it doesn't matter what we do, the sum of all forces has to equal 0. That's that equilibrium principle. The farther the point of force from the joint, the greater the movement arm and the smaller the magnitude of the force. Oh, look, this is also kinesiology, right? The longer the movement arm, the harder it is. This is why most orthoses are designed in long plastic shell or metal bars to run along the adjacent segment, right? If I'm just working on an ankle foot orthosis and I make my ankle foot orthosis only about that big just to cover the ankle, when I put my foot down in it, all those forces are going to be spread about a very small area, right? Whereas if I make the AFO go up to just below the knee, now I disperse that force over a much larger area, which makes it more comfortable to wear. Right? Same thing with something like an orthotic going in your shoe. Sometimes if you just have the little tiny shoe lift and you put that in the shoe, it's really uncomfortable because your foot's just not used to it. Whereas if you get a full kind of molded insert, it's easier to wear because you're dispersing that force over a larger area. So the more we can disperse the force, the more comfortable that orthotic's going to be. The force of the interface between the orthotic and the skin must be considered. If I have plastic and I have a patient that sweats a lot, I may have to think of putting something in there to wick away the sweat. How many degrees of freedom do each joint have? The number of joint segments you're going to cover. If I have a knee, ankle, foot orthosis, a KAFO, that's going to be a lot different than just an AFO. A neuromuscular control of the segment includes strength and muscle tone, material selected, the activity of the client. What are they doing? And the goal of that orthotic fitting is to meet the functional requirements of the client with minimal restriction for maximal function. Patients got to be able to do what they need to do. Let's go for a little bit longer, then we'll take a break here. So what are we looking at when we're looking at considerations, right? Alignment, to correct the deformity. Let's say that I do have scoliosis, right? And it is a correctable scoliosis. So we're going to talk a little bit about that when we talk about the braces. In those cases, that's going to correct my spine. If I have a problem where I'm constantly hunched forward, like I said, and I'll go get my figure 8 brace so I can show you what it is on break. But if I have this kind of deformity where I'm like this, the alignment is going to align me where I'm no longer pulled back like that. Movement. Maybe a joint needs extra assistance with motion or resistance to excessive motion, depending on what we're doing. We may need a hinge joint that actually helps with movement. We may need a fixed joint that restricts it. We have to understand. What's this RGO down here? You remember what that was from spinal cord? AFO is ankle foot orthosis. That's an easy one. What's an RGO? Reciprocal gait orthosis. Yep. I think I totally butchered the spelling there. Did anyone see any of these while you're on clinic? You usually don't see them too often unless you're working in a true spinal cord clinic. But it's basically this really large brace that on the back has these two handles, and you can walk behind them and kind of walk them like a dog. Walk them like a dog, really is what it is. But it allows for them to do reciprocal gait. The other thing it'll do is if they have function in one leg, when they move that one leg forward, it'll automatically start moving the next leg forward when it plants down. So it allows for reciprocal gait. It's actually pretty cool. You don't see those as often as you used to. We just don't do those frequently anymore. They're expensive. Weight bearing. Do we have to reduce axial load? If you got a patient with a fracture, we definitely have to reduce axial load, right? Maybe musculoskeletal disorders, neurological such as CP, stuff like that. Patient that's got ALS, we may have to reduce some loading. Protect the segment against further injury or pain, right? Knee orthoses are big for that, right? Let's say you know that you're going to have a knee replacement. The doc may put you in a knee orthosis for the time being that maybe limits motions or provides support so that you don't get further breakdown in the knee until he gets in and gets it taken care of. You may be in a knee orthosis after something like an arthroscopic surgery, just to provide a little bit of support. Cock-up splints are the big ones. I do have some stuff here, so I'll go grab them on break. So this is where we're gonna take a break, but these are the ones we're gonna talk about a little bit. We're gonna talk about some upper limb orthosis, dealing with the arms, right? We're gonna talk about some spinal orthosis, and then we're gonna talk about some lower limb orthosis when we come back from break. So let me stop share here and pause record. And we are back from break. So we're gonna start talking about some orthotics here. And you guys are going to laugh wholeheartedly here because I just went around my house and saw what kind of orthotics I had laying around the house to use as teaching aids. I just keep them here because they're teaching aids. I've never needed any of these, right? So the orthosis themselves are going to be named by the joints they encompass, right? If we have an FO, it's a foot orthotic, right? What would be an example of a foot orthotic? Not a fortnight, a foot orthotic. A simple what? Yeah, insole, right? A wedge for in the shoe, a lift, yeah. Any of that would be a simple, even technically diabetic shoes, technically would be foot orthotics, right? Dr. Scholl's. Crocs, yeah. Crocs. Dr. Scholl's technically are foot orthotics, even though I wouldn't recommend them, but I mean, they serve a purpose. Ankle foot orthosis. Now we had an ankle. KAFO, knee ankle foot orthosis. HKAFO, hip, knee, ankle foot orthosis. Just a KO is a knee orthosis. A WHO is a wrist hand orthosis. And EHU, I always love the EHUs. I don't know why that one always makes me laugh, but for some reason the EHU always makes me laugh. It's a great name. Do you have your EHU on today? Yeah, I got my EHU on. The elbow, wrist, hand orthosis, elbow orthosis, right? HO could be a hand orthosis. Shoulder, elbow, hand. I have seen the best one I've seen so far was a TLHKAFO. Who? Yeah. That was the biggest brace I've seen to date. Yeah. Basically, it should have just said, you are a robot, right? Thoraco, lumbar, hip, knee, ankle, foot orthosis. And what's funny was with this one, normally this hip would have been changed to an S because usually when you add the TL, it becomes an S instead of a hip, but it was just, for some reason, they left it as a hip. So shoes are kind of the foundation of any lower extremity orthotics. It serves two purposes: reduce weight and redistributing pressure. Zappos. Zappos is huge into making normalized orthotics and clothing that fits around orthotics. Yeah, rip him, yeah. But his company still is really big in this. I'm waiting. They're going to hold it this year. So as soon as I have the information, I'll send it out to you guys, even though you'll be out and graduated and be licensed by then, because it'll be in July. But every year they have a prosthetic runway where they invite the community into Zappos, and they have a little fashion show of all of their stuff for patients that have orthotics and maybe missing limbs and stuff like that. And it's actually pretty cool. It gives great self-esteem for those people that are up there on stage wearing them and stuff like that, which is why I truly do support it. I've gone 3 years now. And usually they hit you up for a donation too, but that's beside the point. That's okay. But it was actually really cool to see the way they've got, dresses designed that somebody that doesn't have arms can still wear it, right? Because think about it, ladies, if you have a long dress and you have no shoulders to hold it up there, that dress could have a problem, couldn't it? Ways to put shoes on, like these shoes over here that open in the back. Nike, I don't know if you guys saw this, but Nike just finally has developed an orthotic shoe for patients who can't tie shoes. I think they're called the Free Airs, I think is what the term is. I forget. I don't remember what it is off the top of my head. They literally just designed it. And it was in conjunction with this kid who wrote Nike when he was a teenager saying, hey, I've got cerebral palsy and I've got spastic cerebral palsy, so I've only got use of one hand and I can't tie my shoes. Why does no one make any cool shoes for me? Fly Ease, there it is, thank you, right? And so now Nike worked with him and designed these shoes that people can put on that can't tie shoes. And they're actually, honestly, I would rock them too. They're actually pretty cool looking. They're not exactly, they don't look like your typical, like this shoe over here, let's face it. This is not exactly a cool looking shoe, right? I mean, it is what it is, but it's definitely not cool looking, right? Well, that was the goal. It's because they got funded by, I think, the Cerebral Palsy Foundation too. But yeah, so shoes form a foundation for AFOs and everything. So here's the difference. So an insole versus an orthotic, right? An insole is what we all have in our shoe. It's designed to kind of soften the blow of the foot. And there are some studies out there, if you look at them, that show that maybe the insoles in our shoes are causing more of our feet problems because we're making our shoes too soft. Right? And so then our foot's not dispersing the force as much. So then we end up with foot injuries and collapsed arches and stuff like that. There is some case to be made for those. What are those weird shoes that are the toe shoes? Are they the Vibrams, I think they're called, or something like that? There's some case, Scoliosis. There's some cases for those. There's actually a research that came to UNLV that talked about that. That was really interesting. I think I talked briefly about that. Orthotics are designed to be strong, rigid, plantar support. So looking at this one, if you look at this, the front of this orthotic is pretty thick and heavy. Now, looking at this, this probably is not for alteration of arch or anything like that. What do you think this is protecting, if you had to guess, because how thick and supportive it is at the front? What type of patient is that going to be for? Who's going to need some extra cushioning at the front of their shoes to prevent pressure injuries? Yeah, diabetics, right? So this is probably a diabetic insert. I don't know for sure. I'm just guessing. So foot orthosis consists of inserts in the shoe, right? And the nice thing about it is it helps to accommodate length. I should have grabbed those. I forgot those. I do have a set of those as well. Where are they? Don't know where they are. Now that I think about it, I'll just find them then. To accommodate leg length differences, right? We talked about that leg length. Which leg length do you think it's going to compensate more for, true or apparent? You remember that true and apparent leg length? True, yeah, right? Apparent leg length is primarily structural, right? So we're going to try to fix that problem. Or apparent is true, we can't do anything about it. It's a shortening of the leg, so we may have to put things in. There are all kinds of modification you can do. We have this UCBL, University of California Biomechanic Lab insert that holds foot in a neutral position. Some metatarsal pads. There are shoes and inserts that help patients that are over pronators, right? Pronators walk on the inside of the feet that force them into a more neutral position. Neutral to pronation is where you kind of want to run, right? Then if you got the people like me that walk on the outsides of our feet that are the supinators, they make shoes and inserts that kind of roll your foot inward. It's easier, well, from what I've seen already, this is, again, subjective, but kind of objective too, working with patients. It's easier to correct an overpronator and bring them back to more of a neutral foot position than it is to bring a supinator into a neutral foot position, because getting all the way into a little bit of pronation for me hurts. It doesn't feel good. I can get to about neutral with my foot, but much past that is really uncomfortable because the lateral aspect of my foot is really tight. I have no eversion. I can do a heel wedge, I can do a met bar or a metatarsal bar, right? Stress across the metatarsal phalangeal joints and the shafts during late stance. You can have a rocker bar, right? This is one that helps with the metatarsal heads and improves late stance movement. All of these are just foot orthosis examples. We can have diabetic shoes. Orthotics made of this Trillium plastizote, offloading shoes, post-op shoes, shoes with the use of the AFOs. There's all kinds of things out there. The number one shoe that you see a lot of patients that wear that have foot problems is this company right here. What company is that? The company with the N. New Balance. Yeah, New Balance has made a lot of the shoes for patients that have problems with their feet. They've been kind of in the forefront of it. But let's just face it, I wore New Balance in school. Yeah, I was going to say, I wore New Balance all through school. They weren't the cool shoes, right? They just weren't the cool shoes. I don't know. I think Skechers might be replacing New Balance's dad shoes now, though. I'm just saying, Skechers with their membrane foam shoes. So here's looking at some lower limb orthosis, right? So looking at this one on the far left over here, right? This is not crossing the knee because the knee would be right here, right? So this would just be an ankle foot orthosis, right? But that's going to be, is that going to be a pretty rigid one? Looking at that? That's going to be pretty rigid, wouldn't you think, with that bar? Here we have your kind of standard ankle brace, and then we get the cutesy kid ones. And the nice part with these thermoplastics, if they go and get custom bracing, this is really cool because, like I said, so Brittany Stryker runs Orthopedic in Motion here in town. She's a really good friend, and they can make these braces for you. And literally, like, say your kid likes, I don't know, some 70s cartoon that's not out anymore. I don't know. Oh, Magilla Gorilla. Yep, the kids with CP, right? Exactly. Say your kid likes Magilla Gorilla and it's an old 80s, 70s cartoon that's not on anymore. They can literally print a piece of paper off the internet with like pictures of it and mold it to the actual orthotic, so it makes it look cool for the kid. They can put pretty much anything on the orthotic, which is just awesome to me. When we were there, they were making a knee, ankle, foot orthosis for a kid whose dad was one of the Thunderbirds. And so they had gone out and take a bunch of pictures of the dad's plane, like actual pictures of his F-16, and put that on the outside of the AFO, which I thought that was just so cool. It is so cool, right? It's neat stuff they can do. I mean, you can have simple stuff like, let's see here. Yeah, there's just a simple ankle brace, right? It helps support the ankles. This is for somebody that's got a sprained ankle. Yeah, that's I only have one ankle support, but yeah. So all of these technically are considered lower limb orthoses. So the AFO is comprised of the foundation, the ankle control, and the foot control. So it's all going to depend upon what they do. The further up proximal that ankle foot orthosis goes, the more dispersion of that force it's going to have. When we're talking about an ankle foot orthosis, we have to know if it's going to be a static or a dynamic, meaning does it allow movement or is it lock movement? If your patient has foot drop, really bad foot drop where the ankle just drops down, are you going to want a lot of motion in that ankle brace? No, you may want it completely locked that they don't go into plantar flexion at all. Or maybe that it limits them to like 10 degrees. So those are the kinds of things we can do, right? We can prescribe the amount of plantar flexion and dorsiflexion allowed in this. Even if we have one that allows motion, we can adjust how much motion we're allowed to have, which is actually really cool. It's a lot better than it used to be. It used to be you just get one brace and that was the way it was. There can be Dorsiflex assist braces, right? These have a little bit of a spring back in the back, either a dorsiflexion spring assist or posterior leaf spring. And they're actually really cool. They're designed so that once you go to toe off, when it feels the pressure loading on your toes and you pick your foot up, the spring cocks back and it brings your foot back into dorsiflexion so that you can do heel strike. So it's actually really cool that it does that, right? So, you know, when you're walking down the highway, or not the highway, not walking down the highway, but walking down the hallway, and you get here to toe off where the toe is the only thing touching, as soon as that leg kind of swings through here, the dorsiflexion spring pulls the foot up so that they can get the heel strike. That's a really bad drawing of a leg. This is why I'm not an artiste. This and many other reasons. You don't have to specifically know it's called a Clensac joint. Don't worry about that. But do understand that there can be spring assist in that ankle joint to allow for dorsiflexion. It's really rare that you're going to see any assist with plantar flexion. Usually plantar flexion is pretty good. because we have that big old soleus. Well, not big old, but that's really strong soleus that helps with plantar flexion. So it's pretty rare that we have plantar flexion braces. We can put a posterior stop back there that limits plantar flexion, prevents knee hyperextension. We can put an anterior stop, limiting dorsiflexion. We can put bilateral locks that limit motion both ways. And then we can have hinged solid foot orthosis, which means that it allows a little bit of side motion, but no up and down. So there's all kinds of things we can do with the entangled foot orthosis. This is just kind of looking through a bunch of different ones. And you can see this one picture here, right? You can see that hinge. And what that hinge is going to allow is a little bit of dorsiflexion. It's got a block back here, right? There's that posterior block. That posterior block is going to limit the person from going into plantar flexion. This one here, solid, not going to be able to do anything with it. Why does this one have so much plastic on the outside here, and this one doesn't have much? What's that going to do? Is this one for like skinny people and this one's for Mr. McKeever-sized people? Anyone have an idea why this one's got a little bit more beef to it? Could be more restriction, right? If you look, there's a lot more down here at the lateral aspect to limit lateral motion and more stable. Yeah, right. So again, think about it. The more that we're touching, the more we're dispersing that force along that whole lower leg. The downside to that is the more that we're touching and the more that we're likely to get what? Pressure injuries, right? Or points of pressure sensitivity. In this one here, right, the small one, let me clear up my stuff. In this one here, the only points of contact are up here, kind of down here, and across the foot. This is a point of contact, but it's barely there, right? So that means we're going to have pressure sensitive areas up here, pressure sensitive areas down here. But in this one, we've got pressure sensitive areas the whole way down that brace, which is going to disperse the force better, but it's also going to cause more likelihood of skin breakdown. And there's Tweety saying hi. So when we get to the KAFO, now we're starting to add knees. Most times with the KAFO, we're going to be limiting hyperextension because we're going to have one of those people that, you know, when they plant down, you know, their knee kind of goes into hyperextension a little bit, right? What is that called? What's that technical term for hyperextension of the knee? It's going backwards. What's the Latin term for knee again? Genu, good, right? Okay. And then genu recurvatum, good. Genu back curvature, recurvatum. Yeah, no, you got it right. You spelled something, you spelled it or close enough. Probably better than I would have spelled it, be honest, Adrian. Genu recurvatum, that back knee, right? So sometimes we have them to prevent lateral motion as well, but most of the times it's to prevent genu recurvatum, patients that are really going backwards with their knees. Simple mechanism is just a drop ring lock that prevents the knee from extending back that or limiting flexion. Sagittal stability is usually improved with kneecap or anterior band straps. Very rarely do we have KAFOs for that lateral aspect stability. Most of the time, if we're going to do knee braces for lateral stability, they're going to kind of look like this one here, where it's just a bunch of straps. Honest, it's only been in a cabinet for like 6.5 years. You know, where this is going to go across the kneecap and provide a little bit of lateral stability, right? These two bars here are going to go right across those, the LCL and the MCL, and provide lateral stability to keep the knee from kind of rocking back and forth. It's very rare that we're going to put something plastic on somebody that needs lateral stability. It's really sad that I have all this stuff. Frontal plane control is achieved with a plastic calf shell, so we can do all kinds of things. So here's kind of looking at a KAFO. And so this allows for limiting motion. We can go in here on most of these, and that dial right there adjusts how much flexion we allow. This one doesn't allow for adjustment. It just locks when it's in standing so that it doesn't unlock when they're walking. So a couple different ones. And we got a little girl here with her cute little KAFOs. Why do you think we're more concerned about locking that knee once they get up? Because if I lock that knee out, am I able to stand usually if I don't have knee control? Yeah, right. I can hang on my ligaments. So I can kind of use that knee lock to get me standing when maybe I wasn't able to stand before. So thinking back to talking about the boards, because everything we're going to do from now on is going to talk about the boards. What level spinal cord injury would you be starting to think of? This is kind of along when we're talking about these prosthetics, which you might run into. What level spinal cord injury might you start thinking that might need something at the knee? Knee flexion is, well, T6 definitely. Yeah, T6 we're going to probably be thinking of hip too. What myotome is knee flexion or knee extension? Think back to that. We're in the what's? The L's. Good, right? So we start thinking about somebody that's, L4, L3, L2, which again is pretty rare, right? We know that in the lumbar section, it's not very likely that they get spinal cord injuries because the vertebrae are huge. But maybe the patient's got a really, really bad compression on that nerve. And so now their knee is not locking out, their quads aren't locking out, or maybe the knee's not flexing or whatever it is, or maybe they lost both. Now we can put a KAFO on them, right? And lock that knee out so they can get functional gait. Whereas if it just constantly buckles on them, they can't walk. So these two here, these are your typical, what I've seen in the clinics called Bledsoe braces, the ones with the little dials on the side. And again, BLEDSO. Your board is not going to ask you about Bledsoe braces, just to let you know. But if you hear somebody talking about a Bledsoe brace, it's usually one that has kind of this dial on the side. And it doesn't matter where it's at. If it's an ankle, they'll call it a Bledsoe brace. If it's a knee, they'll call it a Bledsoe brace. If it's a wrist, they call it a Bledsoe brace. I don't know why. Again. Then we got this one here, right? Here's those 3 points of control, right? The sum of all those forces have to be what? Equal, right? That would be 0. Looking at this one, I'm seeing this as being a poor fitting brace. Because I'm looking at this, I think this force is actually greater than these two forces here. How can you tell? Yeah, the flexion, right? You got a little bit of flexion going on there. So we may have to adjust this a little bit to provide a little bit more back force so that we straighten that knee out. Or maybe the doc ordered it that way and I'm just being an idiot. One of the two. I think it's possible. Mr. McKeever being an idiot? Never. HKAFOs. Now, I don't have any of these at my home. So 50-50, right? Hip, knee, ankle, foot orthosis. I haven't needed any of these yet. Knock on wood. Just saying. Now includes a hip joint and a pelvic band. These are used less often due to discomfort of the pelvic band and limited hip motion. The other problem with these, as we go further up the leg, the harder it is to get on independently. Of the HKAFOs I've seen, I've only ever really had, and in my whole career, I've only had one patient that had one of these that could get it on himself. And he was a trooper too. Like literally, he could just don that thing like no tomorrow. But most of the patients I see with HKAFOs usually need help. So this is kind of what it looks like here. And I guarantee that nobody looks this happy in an HKAFO. right? So with this one here, you can see I've got a control for hip flex. Oh, that was a bad arrow. I've got a control here for hip flexion. Looks like subword. I've got a control here for knee flexion, and I've got a rigid ankle, which, kind of thinking about it, makes sense, doesn't it? Because if I've got my hip knocked out, am I going to have a lot of ankle control? No, not really, right? I mean, maybe if the hip's the problem, but typically if I've got that hole knocked out, that ankle is going to be my least concern. I'm be more controlled about this. And why do we allow these motions at the hip? For some normal gait and also for the patient to sit down. But he just looks so, look at that smile. Looks so happy to be in that. Never have I seen a patient that happy. That's an A1 smile, man. He went to Aspen Dental. Typically, the thoracolump hip, the KFO, typically not used, again, maybe with the reciprocal gait orthosis. They may be used in standing practice. I have used THK-AFOs to put it on a patient to just get them up and standing and weight bearing. But here's my thought process on this. If I'm going to do this, I might as well just put them in a stander, because a stander is going to provide a little bit more support and they're going to feel a little bit more stable than one of these. So I might as well get a stander out that helps me and reduces my workload on getting the patient up. Because if I put one of these on, guess who's getting that patient out of bed? Not the patient. It's going to be me. And it's going to tear my back up. And I'm not about tearing my back up. Here is an RGO. This is a big one. This is the new cybernetic one that's out there. This is Terminator, right? But here's the deal. You know, these things are getting more and more common. Right now, pretty much the only way you can get this type of stuff is if you're in research in the military. You know, if you're injured in the military, there are some vets that have gotten this, not many, right? But as this becomes more and more common, think about how cool that could be if you get a spinal cord injury and we can get you in one of these and you can still walk a little bit. Like, to me, that's just, that would be a dream if I was a spinal cord injury. I don't know. You know, even knowing that I'm not the one doing the walking, that it's the machine doing the walking. I don't know. They had a neat one I saw the other day that I was watching on the line, that the guy controlled it with a PlayStation or Xbox controller. So the orthosis went on, and then he could put his hands here, and it had a little controller that he could use that helped pick up his legs and walk. Right? We're getting closer and closer to, what was the thing from Skynet taking us over? Here's a couple of different ones. These are your traditional RGOs, right? This is the one I've seen before and used before. Is this one back here with this bar, because that's the one I've used before where I've helped patients walk. But they're all there. But you can see these. Is this going to be are these going to be a lot of fun getting on the patient looking at this? Yeah, not at all. Right? So you got to imagine, Forrest Gump, right? So you have to imagine thinking about this, though. Because in order to get these, that means the patient probably has almost no control of the lower body, right? That means getting them to roll around and get stuff in and stuff like that. No go, Forrest Gump. You're going to be moving them around yourself. So it's going to make it more difficult. Dr. Vreskin says hi. Hold on a second. All right, so she is finishing off stuff for your clinical. She said to tell you guys hi. So here's more of those RGOs. These things, just like I said, when I put these on, the fastest I've ever gotten one of these on is about 35 minutes. So you got to think about this. I get it on for 35 minutes. I maybe get 20 minutes of therapy out of them, and I can't bill for that 35 minutes I'm putting the orthosis on them because I'm not really doing anything therapeutic. So this has to be a clinic that really specifies that we're dealing with spinal cord injuries, and that's just the way it is. Other things we can have, right? There's all kinds of orthotic options for patients with paraplegia, mass-produced, standing frame and walker, the parapodiums, custom-made orthotics, stabilizing boots. The Craig Scott KAFO is one that I've seen the boards ask questions on. I think I had a picture of it back here. Let me go back real quick. I thought I had one of those. No, I don't have a Craig Scott picture here. A Craig Scott KAFO is one that here's the part above the thigh, right? Here's the ankle foot orthosis down here. They're connected by this metal bar, and there's a hinge about here. In the back, there's this loop that goes around like that. And what that loop does is when they're ready to sit down, they can pull up on that loop and it unlocks the knee. Is that one? I don't want to click on it because it'll take me out of my thing. So if you found a picture, cool, thank you. RGOs, externally powered orthosis with pneumatics or functional electronic stimulation are out there. There's all kinds of things out there like that. All right. Here's a standing frame I've talked about multiple times, right? I've talked about this back in pediatrics. I've talked about it, you know, even now. So it helps them stand up. But as you can see, you're just going to slide them in this little, I don't have my drawer up. Slide their butt in this little sling here. And then this pump, you're going to pump down and it'll bring them up to vertical. Now, the important thing to understand here is because parents, if you're working with kids and you put them in these standers, oh my God, my baby's standing up. Look at that. He's going to be able to walk soon. Right? That doesn't mean that this patient's going to be able to walk, but why would it be good to get them standing up like that? Like stand them up like that for 20 to 30 minutes. Why would that be a good thing? Strengthening their muscles, good. If they have it, what if they have no strength in their muscles? Their muscles are dead. Why else might it be a good idea? Get them out of hip and knee flexion, good. There's a great one. Stretch. And the other thing is we know that weight bearing, what does weight bearing do to the bones? Yeah, it makes them stronger, right? So just getting them up like this. And if you're ever working in a school therapy, you'll be seeing a lot of these. If you're ever a PT in school therapy, I saw this when I was back in Pennsylvania at the one school I worked for, where a lot of my day was going classroom to classroom, putting people in these standers and taking them out of the standers. So we'd go into like classroom 2, we put little Johnny in the stander, set a timer for 2 hours, go over to the next classroom, get little Annie in a stander, come back and get Johnny back out of the stander 2 hours later, because it was really good for them to get up and standing for a period of time. So here's a parapodium, similar to a stander, except this part, you don't have all those nice, this kind of reminds me of Hannibal Lecter here, to be 100% honest. But the parapodium allows them to stand up. And the other thing a lot of these usually have, usually the parapodiums more than the standers, usually have a desk here. So a kid can actually do some schoolwork. I prefer the stander because here, who's getting this patient up and standing in this parapodium? Who's doing all the work? We are. There's no sling to lift them up. There's no, pneumatic handle over here to get them standing. This is 100% gyras lifting that patient and getting them up into that. Now, if the patient's got some functional muscles, that may not be a problem, right? Maybe you've got a kid with muscular dystrophy, and that's what this kid is. This is actually from the Muscular Dystrophy Foundation, I believe, Orthotic Solutions. They spelled it wrong. But, you know, in that case, yeah, these are good. The other thing this does is it allows them to move them around the classroom, right? For teachers, this can be a really big thing because maybe you're doing artwork over here and then you're going back to your desks. If the patient's in the standing frame, it can be a little difficult and unwieldy to move them around, whereas this one, they can slide around pretty good. Trunk and spine orthosis. LSOs are out there, rigid orthosis, custom LSOs and TLSOs. With TLSOs, again, you're gonna see these names, the Taylors and the Jewetts. Those are the companies that make them. And you may see a Knight Taylor or a Knight Brace as well. There's cash braces, all that. I have, where did I put that one? So I have like this simple one right here, right? This is nothing more than a corset style brace. We call it, in the hospital, we call these abdominal binders, typically more than corset style braces, because what this is going to do is once we put it together, it's going to bind the abdomen and provide a little bit of posterior support to the spine. In reality, with patients with spinal cord injuries, this isn't very useful. It's better to have the plastic braces and the hard braces for that than this. Corsets, abdominal support, which I just talked about. I don't think I have any, that's all the lumbar ones I have here at the house. I had that for when I strained my back. But again, it was one that you're going to want to watch using, because if I wear that long term, I'm going to get weak. Here's a cash brace. This is kind of one. Is this one going to provide much support? Looking at this brace, what do you think this one's for? Posture, yeah, right? So maybe I've got a small proprioceptive feedback and posture. Maybe I've got a small fracture in my spine that doesn't require surgery or something like that. But if I put a lot of anterior pressure, it's going to get worse. So I can put this cash brace on them and it'll keep them upright. And she just looks so happy in it as well, doesn't she? But it's just kind of that providing those 4 bars and keep you into extension. Here's kind of your typical LSOs and TLSOs that you're going to have. They're not that bad for getting on patients, but they can be a little bit of a wrestle sometimes. Ladies and guys that are going to be working with ladies, this area can be the problem. If you just get custom off the rack orthotics. Because, you know, I'm a guy and I've learned one thing over the time period, not all ladies are structurally the same. And so getting just that custom, that generic orthotic off the shelf, especially if it's got a sternal component, you may have to get a custom sternal component fit because not everyone's going to fit into them. I think you can figure out from there what I'm talking about. So a lot of times we're just going to not use that component at all on a patient that's got a low back injury because, you know, that gets in the way. The other thing then you have to think about, though, is then you've got something kind of hanging over the brace, which creates an area of pressure. You have to kind of think about all of that. Here's the Jewett brace, right? Again, more of a proprioceptive brace. But this one has a little bit more rigidity than the cash because it's got these lateral component support. So it's a little bit better as far as providing actual support. It's got all these keys and fun stuff over on the side here that we can adjust how much extension and hyperextension we want with the patient. Cervical orthosis. The most common cervical orthosis you'll see is just a cervical soft collar. Right, those are just those ones you see whenever you're watching Law and Order or was it Houston 911 or one of those shows. That's the one that you see the fireman put immediately on the patient that's in a car accident. Right, it's just that soft collar that keeps them from moving. And then we've got the Philadelphia, the Miami J, and the Aspens. So this is what I was kind of talking about. So Aspen, let me see here. Aspen is the brand name. This is a Vista Aspen brace. And don't look in the inside. That's a really nasty brace now that I look at it. But this allows for protection. And remember when I talked about having area, I've got area for a trach here, right? So that I can get into the throat if I need to. But the neat part about this brace, specifically the Aspens, is this little knob up here. And this little knob I can turn to adjust my chin pressure. So I can have the patient either in a downward position or I can put them all the way back into hyperextension. So honestly, I prefer the Aspen collars when I'm working with a patient, but this just literally goes on and keeps their neck straight. This was the one that I had the last time I broke my neck. Time 2, by the way. For post-cervical orthosis, then we'll talk also about the halo, right? So here's the halo vest. This is probably the most restrictive brace that you're going to have. The halo vest is literally going to lock your head and your shoulders together. This has to be done in the emergency room because they are going to drill it into the skull in order to lock it in place. It is getting locked in up here. We talked briefly about this. The one thing I want to say here is the upright handles of the halo are not, or the upright bars are not handles. Do not grab a hold of that to help them get out of bed. I've seen it. Don't. Bad PTA, right? I've seen PTAs that will grab the back post in order to sit them up. Screwed into the head. Ow. Right? Always with the halo, somewhere on the halo or on their person should be the screwdriver to adjust the halo. Because sometimes the halo moves. And so they need that. It's a very special, it's usually usually Torx bit so that it can't be screwed with. And it's also got some breakaways. So here's kind of the soft bone collar. Here we're looking more at the Philadelphia. Again, the Philadelphia just has this opening for, the difference between a Philadelphia and a soft collar is the opening for the trach. That's it. Then we get into kind of the Miami J. And again, if you look, the main difference between the Miami J and the Aspen is what? What does the Miami J have? A little bit of what support? Sternal padding. Yeah, it's got a little sternal padding, right? When I came out of surgery, this was the one they had me in because it kept me from doing anything. I was locked. There's kind of that Aspen collar, the Vista by Aspen. Here's a rigid cervical brace. Now, this is not a halo, but so let's say I was in this Aspen collar. Why might the doctor instead order this? What do you think the reason he might upgrade to that is? If I'm not what? Wearing my collar, I'm not being compliant. So I tell my patients that. I'll tell them, look, this is easy. Wear this, please. Because if you don't wear this, we're going to put you in one of these. Because this goes on and typically doesn't come off. It's much like the halo. It only comes off to change clothes. Upgrade. Here is that halo brace. Right? You can see those pins are going into the outer bone layer of the skull. And I don't know if I told you guys this, but they have to keep you awake for that. I still have my pinholes. You can actually see one right there. If you look, do you see it? You know, see that little pinhole there? When I had it, it was great. But that brace doesn't come off at all. And I will tell you, if you want to talk about the funk, that brace gets the funk. Because you're going to be wearing that. I wore that for 7 months, I think, or 6 months or something like that, straight. And you can't take it off because it's screwed into your head. When you go to the doctor, sometimes they'll take the chest component off. They'll unhook you down here for a brief period just to change them out. But for the most part, yeah, that's on you for good. Do some really bad. Why do those pictures look so bad in this PowerPoint? Ugh. ladies, if you have this halo, I'm telling you, I can see that this lady has looks like a sports bra underneath her halo. Oh yeah, bad. You got to think it's putting pressure on your skull. Yeah, it is, right? But I was just showing you guys here. So this nice young lady here's got a sports bra on. I'm telling you, that's not a real halo. Because how's she going to put that on and take that off? Doesn't work that way. Right? Most of the time that I had that, guess what was the only type of shirt I could wear? Button-up flannels. Because I needed something I could just slip my arms in and kind of wrap around. There's a child with an axial subluxation. So let me ask you, let's take this back to patho really quick. What condition leads to atlantoaxial subluxation? What pediatric pathology? That leads to atlantoaxial instability. You have a few guesses. I'll throw one out. It's not cerebral palsy, because that's a problem with the brain. There you go. Good job. Good guess. Was that a guess or did you know that? Educated guess. I like it. So if you remember, or maybe you don't remember from back in patho, with patients that have Down syndrome, they have a really weak atlanto-occipital or atlantoaxial ligaments. So those bones shift around a lot. That's why we don't want them doing contact sports and don't want them doing like gymnastics and stuff like that. So that allows for that so that, you know, if it slips around. So this patient's got probably has Down syndrome. I can't confirm that, but that's a good likelihood. Scoliosis braces, right? This is for curvature of the spine. We have Milwaukee's and Boston's. So this is going to put pressure. And I just want to talk about this real quick, just because I know that one of you asked a question about this a few weeks ago. Remember with scoliosis, you're going to have a primary curve and a secondary curve. Which one is the problem? The primary or the secondary? Primary. The primary is the problem. The secondary is caused by the primary. Does that make sense? So like if I have an upper spinal curve like this, my body is then going to curve the top part of my spine to get me back to neutral. That's going to be my secondary curve. Does that make sense? Right? So when I have this primary curve, I have to push on that curve to get it to go back to neutral. So if you are looking at, and scoliosis is going to be named for the lean of the primary curve, the lean of the primary curve. So the outer hump of the primary curve. So this lovely lady here in this picture here, right? Which is the most anatomically correct picture I've ever seen. Does she have a right or a left scoliotic curve? You got a 50-50 shot. Okay, so I got one voting left. They changed it to right. Is that your final answer, Adrian? Right would be correct because her curve is probably going like this. Right? This is my area of pressure pushing over. So looking at this brace, because this is actually a question you may get on your boards. They may give you a picture of a scoliotic brace and ask you, does this patient have a right scoliotic curve or a left scoliotic curve? And the curve is named for the direction that it goes, right? So if this is my left shoulder, this is my right shoulder, her curve is going to go to the right. So she would have a right scoliotic curve. Does that make sense to everybody? Right? Correct. So this is going to be pushing on that curve. Now, what about the secondary curve? Okay, secondary curve is probably going to be a left curve. Good, right? Exactly. But why are we not so worried about it? Excuse me. So the left curve is probably a functional curve, right? Yes, it would be neutral after we fix it, right? So after we fix the primary, yeah, the secondary will fix itself. You're exactly right. So that's a functional curve. The second curve is formed because of that primary. Now, could that eventually become structural? Sure, if they don't get any correction for it. It could become structural, right? But if we catch it early enough, we can kind of straighten them out, and that secondary curve will reduce itself, or will take care of itself. But remember all of this when I'm talking about these curves, because we have two different types. We have structural curves and we have functional curves. Even for the primary, we can have a structural and a functional. So for that primary curve, if it's due to posture, so if my primary curve, my hump, is because I just have really poor posture, maybe I sit like this all day, I can develop a scoliotic curve from doing this. If I do this all day long, eventually my spine will curve that way. That will be a functional curve. A structural curve would be where maybe one side of my vertebrae are a little bit thinner than the other side. Now that's going to curve. Now we're not going to be able to fix all of that. We can correct it a little bit. Depends upon how it starts. Yes. Right. Most of the times for most kids, you know, when I say kids, I'm talking adolescents, it's usually a functional curve. Right. That's why in school they do what? Or they used to. I don't know if I hope they still do it. They do that scoliotic screening, right? Where they have you bend down and touch your toes, and then the nurse or the doctor checks your spine. Do you remember that? Do they do that to you guys? Don't do that anymore. It's probably picking on kids or something like that. But the thing is that caught a lot of functional scoliosis. So some schools do and some schools don't, it sounds like. That caught a lot of functional scoliosis when I was coming up through and got kids to not have, you know, humps, right? Speaking of that, quick joke for you. You know that Quasimodo played football for the University of Notre Dame, right? You know what his position was? Halfback. No, no one got it. All right, a couple of you got it. Some of you just don't know who Quasimodo is. Go watch the Disney Notre Dame movie. But remember, if it's a true structural, there's not much we're going to be able to do. Right? Quasimodo would be an excellent example of it. That was a structural problem with his spine. We're not going to be able to fix that in PT. All right. So you can even see on this one over here, the girl with the brace on, you can see her primary curve is that bad, can't you? I mean, her whole torso is twisted. So just remember that, you know, functional, we can usually correct. You can tell by the shoulders too. Yep, look at that. Right? Why are her shoulders like that? She's probably got a tertiary curve. Right? So she's probably got a curve up here. Let me get my little drawer back again. She's probably got a curve up here, correcting for the curve down here, that's correcting for the curve down here. So here's my primary curve, right? Then I get a secondary and a tertiary. It doesn't really matter which one I label. Right? The top one could be the secondary, the bottom one could be the tertiary. It really doesn't matter at that point. She's got 3 curves. Now she's young. We correct this early, and she may not need surgery, which is obviously the better way to go about, right? So here's a couple of different scoliosis correcting braces. So I don't know why they blanked out one spot on this picture, but that always made me amusing. But you can see, right, this is not a bad one. But look at this here. This is her before the brace, and this is her with the brace on. Is that a huge difference? Do you think this is going to be comfortable for her? No, it's going to suck. And I tell my patients that too. Like if I'm working with kids, I'm like, look, I know this is going to suck. It just does. But if we get through it and we wear it now, hopefully down the line, you won't have to wear this ever again. Right? And usually you can get some buy-in from them. There are all kinds of NFL players that actually have had scoliotic curves that have been corrected. So if you can find it. So this is a Boston. This is a little different than that last one. The Boston's more of a plastic clamshell one. And again, this one over here is actually pretty difficult because this is like a triple correcting brace. So it depends upon what we're looking to correct. And again, these are more, when you hear Boston scoliotic brace, it's more of a functional curvature. Usually, and a lot of times I see the Boston ones are on adults. Why would an adult develop a scoliotic curve? Yeah, working, right? What if I'm like leaning over a machine all day and I'm pushing over, I'm using buttons on this right side constantly, and I constantly got that little bit of a twist going on my spine? I can develop a functional curve as an adult. And the patient comes in and goes, yeah, right here, across my ribs gets sore really easily. Right? Why are the ribs getting sore? Well, because the ribs are twisting too. Right? If you twist the spine, the ribs got to twist too. So we put this on them and they're like, oh my God, my back pain's better. Well, duh. And so how long will they wear this brace? Until that structural deformity is corrected. But if we do put them on this, right, what else are we going to have to do to their muscles? We're going to have to stretch and strengthen. So let's talk briefly about that before we move on. I've got a page. Let me see. Does the other page have a better white spot? There we go. This one's got a good white spot on it here. All right. So let's say I have a patient with a right. So we'll go, this is left. This is looking from the back. This is right. So they have a right scoliotic hump. And don't call it a hump. I just realized I said that. And that's really not appropriate. Right scoliotic curve. So the paraspinal muscles, which are the muscles that are going down the sides of the spine, right? Which side is going to become stretch weak? The right sided paraspinals or the left sided? Which ones are becoming longer? The right sided. Good. Right? Does everyone see why? So this hump is forcing them to lengthen out across that hump. That means my left ones, if these are becoming lengthened, what's happening to the left ones? They're shortening. Good. So now your PT orders you to work with this patient. That means you have to stretch one side and strengthen the other, right? So we are going to stretch which side? We're going to stretch the short side. We're going to stretch the left side, right? And then we're going to strengthen the other side. So how can we stretch that left side? Well, we could have them lay on a TheraBall and kind of lean down and reach over. We could just have them sit in a chair and reach over like that. And that can help stretch out that left side, right? How can we strengthen the other side? What could we have them do? We could have them doing trunk bends, right? Lay them the other way on the ball and have them lean up into it, right? We could do the same thing on a mat. Although Matt might get mad if they're laying on him. No? Okay, fine. I thought it was funny. Does that make sense? Let's do one more just so that we're clear on this. Clear all drawings. So now let me get here's my spine. I've got a left curve. So this is left, this is right. I got my paraspinals coming down. They get shorter. They got longer. So this is a left scoliotic curve. With a left scoliotic curve, what side are we going to stretch? The right side. Good, Dylan. Good. That means we have to strengthen the left side. That is a very common board question. So here's my suggestion if you get this question on your boards. Draw your scoliotic curve and do exactly what I just did there. Does that make sense? Because that way you can think through it. Now, if you're a good person and it just in your head clicks and it makes sense, perfect. Don't worry about it. But if you're not a person that it clicks, draw it. Here's a Milwaukee, all those fun braces. Upper extremity orthosis. We don't cover a lot of these just because this is more hand therapy, but we can have a WHO, we have finger orthosis, elbow orthosis, shoulder orthosis, all these. I've got a whole mess of these. So here I've got a wrist orthosis. I've got a soft wrist brace. I use this sometimes when I'm doing a lot of coding just to provide some padding to my hand. Technically, this is a mouse wrist rest. Technically, that's actually an orthosis. Here's your typical cock up brace for carpal tunnel, right? Let me turn it so you can see it's cocked up so it extends my wrist back some. Here's the other side because I'm lucky and I have carpal tunnel on both sides. So those are all kind of wrist. And then the one that I've been using a lot lately is this little thing here. This is called a wrist widget because the H is, yes, thank you. Hand or humeral, depending upon, well, it could be hand too now that I think about it. This is a wrist widget. I have TFCC instability. So this allows me to do stuff on the computer and not be in a ton of pain because it provides me with a little bit of stability at that TFCC joint. These things are fantastic if you're a gamer. I'm just going to say it, but don't wear it long term because your hand will get weak. But it's amazing how much this relieves wrist pain when you're playing games. I'm not getting paid by Wrist Widget to say that. Use code McKeever. No, just kidding. You mean like this? Mine even lights up. And then this is kind of what I was talking about earlier, which is this figure 4 brace. Right? So this figure 4 brace goes across your shoulders. I don't even know if I can get it on today. We'll see. Yeah, it's not going on. It's somebody else. I think I was using this as a demonstration. But as you can see, if I tighten this down and fix it and get it all straight, it'd look a lot better. But then I can pull on these shoulder straps here, right? Yeah, HyperX makes one. I can pull on these shoulder straps here. And what that does is it pulls me back. And now I have positive, I just have a little bit of positive support back here. The only downside to these straps is this, because it does tend to put a little bit of axillary pressure. I really want to get like thinking about designing a better one of these because like this one, if I wear this long term, my armpits hurt. I can send a link to them. If you get them, I'll recommend 2 different ones. I like the one by Chirp. It's a little bit more expensive, but it works. But also the HyperX one I really recommend as well. But those help correct upper posture. If you have a kid, those can be really useful correcting their upper posture. I'm just telling you, when you see them over there playing Fortnite, like Gyra looks like most times. PT management, PT will perform a pre-orthotic assessment. If the orthotic is recommended, consult will be placed. The PT should be present at all possible times. Now, that's not always going to be the PT. This may be us. The PT may just order the orthotic, and we may be present at the delivery. Prescribed orthotic drive, it has to be evaluated the patient. They're going to have to show them how to put it on, take it off. What happens if you don't know how to put on and take off a brace? What should you do? Ask and practice. right? So before you go into that room with the patient, try doing it yourself. Make sure that you understand how to put that brace on, how to take it off, because if you do that, you look less like an idiot. Just saying. I've seen PTAs and PTs that go into rooms to try to instruct how to put a Jewett brace on, and they have no idea where the straps go. Or the best is the knee immobilizers. Those just amuse me every time. They're such an easy device to put on, but for some reason, like, you fall down the stupid tree putting one of those on, and you can't figure out which strap goes where, and it gets all confusing. So mess with it a little bit before you go in, just so that you understand how it works. It makes you look a lot more competent. We may work with the patient accepting the orthotic. Patient's plan of care may be needed to evaluate once a custom orthotic is available due to new goals. So if we ordered an off-the-shelf one for a time period and they're getting a custom one, be sure that they get an updated plan of care once the one's in. We have to do static and dynamic assessments. We have to see how they do seated, see how they're moving, right? And then we have to facilitate the orthotic acceptance, meaning we have to get them used to wearing it. There should be a wear schedule. Like, today I need you to wear it for 4 hours. Tomorrow I need you to wear it for 6 hours. And it should be building up to whatever the max time is. Donning, right? If patients are using AFOs, make sure they're using clean socks, right? Don't ever wear an AFO with no sock. Oh God, that's just nasty. Even if you're gonna wear a sandal, I don't care. It's better to wear socks with sandals than it is to wear a barefoot and an AFO and a sandal. The road is so unbearable, like wearing socks with sandals. Standing balance have to be tested, so we're gonna have to work through all of that. Gait training, how are they able to take steps? Are they able to advance both legs? That type of stuff that we're gonna have to do. Can the patient push off their chair, or is that AFO or that restrictive device restricting them? And then finally, final assessment, usually completed at home, right? How are they able to do their normal stuff at home? I really like if we can get a home assessment a day or two after they discharge from the hospital, just to see how they're doing with that brace at home. Because usually what happens in that home assessment is you go to see them at their home and the brace is over in the corner. Well, you know, I was okay while I was in the hospital, but now that I'm at home, it's really hard to put on and off. Or the fun one is if you've done any outpatient, the patient won't wear the brace. You'll see them putting the brace on out in their car and then come in with the brace on. And then as soon as they walk out the door, you see them pulling the straps of the brace. Capacities, we have to know what their capacities are, right? How much energy is needed to walk with it? How much energy is going to need to put those on, right? A lot of times with spinal cord injuries, especially paraplegics, or even a hemiplegic sometimes, we have to concern that energy. If it's going to take more energy to put that brace on and take that brace off, it may be just more beneficial for them to have a wheelchair. So we have to think about that. Energy gait with a hemiplegic is not as energy consuming, but we still have to be thinking about it in case spasticity goes up or flaccidity goes up. So we have to be thinking about it when we're working with these patients. Let's take a 10-minute break here. So I'm going to stop the share, pause, resume recording, and we're back from break. Thanks for that commercial break. Sponsored by, no, just kidding. We talked about the O's. Now we're going to talk about the pros. So prosthetics, right? A prosthetic is an artificial device used to replace a missing part of the body. And prosthetics are not just for humans anymore. Yes, I know, look at the Goggie. The Goggie's got prosthetics too, right? It used to be that it was just for humans, but now we've got stuff for Goggies and for kitties and horses and all kinds of stuff like that. So if we're going to have a prosthetic, usually the cause for a prosthetic is going to be an amputation. And we talked about the different vascular diseases that can cause it, or it could just be a congenital amputation, that they were born without a lower leg. That happens too. So with the surgery, we talked a little bit about this, where the surgeon's going to have to go in and bevel the bone to make it nice and smooth. Usually going to have to resect the nerve so that there's not a lot of sensitivity down there. Do the contour of the flap, how the soft tissue goes on, the closure, the bone length. All of it looks really rough when they come out of surgery. All those prosthetic parts when they're doing an amputation man, it looks rough. The bone length is important because the more residual bone we have, typically the more we have to spread that force out across things. Whereas if you only have a little bit of bone, obviously that lever arm gets a lot shorter and more of it's going to be on the prosthetic, which does reduce a little bit of stability. When he's doing a soft tissue, we talked about this when we were talking about amputations. A myodesis is a muscle to bone fusion. A myoplasty is a muscle to muscle. You do have to know those terms, right? So let's say I'm doing a quad, or I did a Bologna amputation, and I've got my quad tendon, and I have to reattach that to the bone. That would be a myodesis. If I do an above knee amputation and I'm attaching the quad tendon back to my hamstrings, that would be a myoplasty. So here's when we're looking at the different types of amputations. And out of all of these, I'm going to tell you, for whatever reason, the board really likes to ask questions about foot amputations. I think it's because of diabetes. But when we're talking about it, we can have toe amputations where we lose part of the toe, right? Or part of the toe, the toes. We have a toe amputation down here, right? We can have a transmetatarsal, which is going to go across the metatarsals. We can have a Lisfranc. What do you think a Lis, looking at that picture, let me clear my drawings. What do you think a Lisfranc is going to do, looking at that picture? Yeah, remove the tarsals, exactly, right? So we're going to be left back at the cuboid and the cuneiforms and that, right? And then we have a Chopart, which comes down through and removes those. You can have a hind foot, such as a Boyd, where they're removing part of that hind foot as well. And then the Symes is usually your most common one you're going to hear about. When you hear Symes amputation, that means it is an ankle disarticulation, right? So that means they lose the whole foot and nothing but the foot. When I think of a Symes amputation, there was, I think it was The Great Adventurer. There was a Disney or an animated film a while ago that had a bat that had an amputation. It was like, my foot, my only foot. That would be a Symes amputation. As we move up the leg, below knee is about mid tibia. Short knee, just below that tibial tube. A knee disarticulation, the femur is fully intact. Then we have long above knee, medium above knee, short above knee. I've never seen this very short above knee, but I guess it exists. That's right at that femoral neck. Then we have our hip disarticulation and our hemipelvectomy, half of the pelvis being removed. Out of all of those, do those names make sense to you? Right? So out of all the foot ones, the ones you are primarily going to be questioned on are the toes, transmets, and then the Symes. You're not going to have to know the difference between a Pyrgoth and a chopper, or the Pyrgoth and a, what do you call it? A Lisfranc. Okay, so you're not going to have to know the difference between those. You do have to know that a transmetatarsal goes through the metatarsals. A Symes is a whole foot. All the leg ones kind of make sense because they just are named for where it happens. So here we have a couple different partial foot prosthetics. This is to replace things, right? This one up here is to replace a big toe. Then we got the one to replace all the toes. Then we've got a foot. Something's a foot there. We got a couple other cosmetic feet here. And again, the main idea is to try to make them at least functional back to where they were before they had the amputation. Symes amputation. I knew I had a fun picture somewhere in here. So this is a procedure of a radical disarticulation in the foot, right? The foot bones are removed and the malleoli most often are beveled or shaved down. Heel pad is wrapped distally and thus allowing weight bearing on the residual limb. So again, we're going to take that tibia, we're going to kind of shave it down and make it nice and smooth so we can slip that right down into a prosthetic socket. I love how this looks like they're using two forks too. Just always made me amused. I don't know why. Real quick, also, I mentioned this before. This little tube you see coming out here, that is a JP drain. That is a pressure related drain. So there's going to be a little ball attached to it at the end that gets squished. And that squish creates a suction force. And as the blood kind of gets sucked up in, it's going to expand out and fill up. And then you empty out the little blood cup or the little blood thing, and you put it back on and you squeeze all the air out of it, attach it back on, and it creates another suction and will help pull excess blood out of that surgery site. You'll see them a lot on cervicals and lumbars and total knees and total hips. But that, if the doc says about a JP drain, that's what they're talking about. So prosthetics, we can use endoskeleton prosthetics using aluminum, titanium, graphite, carbon fibers becoming a lot more and more frequent now. They have interchangeable connectors, other components such as knees, feet, ankles, stuff like that. Structural strength is from the central skeleton-like components. So when you're getting a prosthetic, it's going to have a part that replaces the skeletal component. That is the part that's going to provide the structural strength. Why can't I speak? Structural strength to it. And then the shape is going to be cosmetic, right? We went back here. If I went back to that runner back here, right, at the very beginning, that doesn't look like regular feet, right? It doesn't look like a normal leg. So why are these? These are designed for running. Well, maybe when he's not using those for running, he may have ones that look like more regular legs. And again, that's just purely cosmetic. The exoskeletal prosthetics are the older design with outer plastic laminated shell with wood or urethane. When you hit endoskeletal are the new ones that have a central support skeleton. The exoskeletal ones, think peg legs, because peg legs would be an exoskeletal one. They're the much older prosthetics. You don't see them a lot nowadays. So kind of here's an endoskeleton, right? You can see that that's got that nice bar right down the middle that replaces the tibia, right? And then here's the exoskeletal. So this support is provided by this whole shell out here, rather than a nice kind of solid bar. I prefer the endoskeletal ones. I find the patients have better compliance with these and they have better mobility. The exoskeletal ones are big and bulky. So transtibial below knee amputation, this is where we're going to do. I always thought when I see this kind of looks like the alien from Alien. But what do I know? Now you can't unsee it, can you? For those of you that have seen Alien. Looks like a face hugger before it opens up. But here, so they're going to come in, bevel off that tibia and fibula. And this one here, they're actually keeping the fibula. They don't always do that because fibula is non-weight bearing. They're going to trim down. They're going to have all this excess tissue. Then they're going to take that flap, roll it back, and then stitch it back up. Right? Right. It does look a little bit like a burrito. You're right. Transfemoral, same idea here. We're going to come in here. And now this always reminded me of like a fish opening up. They'll come in, they'll resect the skin back, so flail it back a little bit, roll it down. They literally roll the skin down, skin and muscle down the bone, and then they go right between that bone, and then they close those flaps back together. That's probably, if you get a knee disarticulation, that's probably, if I'm going to get a knee replacement, or not a knee replacement, amputation, this is probably the one I'd want, honestly, because with this one, you just lose the tibia and fibula, and you just have that whole femur to provide structural support with. I don't know, I've seen a lot of patients that have really good service with this, and then they may have to re-tendon or re-anchor the quad tendon somewhere else. Hip disarticulation, now we've got to replace everything up to the hip. And up in here, this is going to have a little socket that you put, or sock that you put over your area, and then they can sit in this. And this is not going to be fully functional gait, but at least they can walk with it. When we're talking about prosthetics, manual locks provide maximal stability. So a manual lock is a knee that's going to lock in place and stay locked while they're walking. And that can then be unlocked when they need to sit down. So a manual lock at the elbow would keep me locked into extension so that I can reach for stuff and stuff like that. And then if I need to bring stuff back to me, I've got an unlock that I can unlock it and bring it back towards me. Fluid controls, fluid controlled locks and everything like that are going to be used for more active individuals. So a more fluid controlled bearing based prosthetic is going to be better for somebody that's more active and up and running. When they're going to get an amputation, we are going to be called in pre-surgery. Why are we going to be called in pre-surgery? We have to teach them stretching. We have to teach them strengthening, right? We may have to consult with the doctor and tell them maybe the patient's not going to be we don't think the patient's going to be compliant. Ideally, when I was at the hospital that we did a lot of amputation at back in Pennsylvania, we wanted to see them 6 weeks before surgery. But usually we saw them about a week because the doctors always forgot to send them to us. But that way we can get them in and start them on a stretching program, start them on a strengthening program. So that once they get that amputation, they're already further along. And what we found is if we did that, the patients had a better outcome from their amputation, and they were more likely to fit in their prosthetic. So post-op, this is we talked about a bit. This is kind of looking at those pictures. Post-op, they're going to have this really rigid dressing. And remember what I talked about when I talked about the dressings. What is the #1 job of the dressing? You remember when we talked about this with amputations and wounds? What's the #1 job of the dressing? To do what to the limb? Protect, okay, protect. And there's one other thing. To shape it. Right, we have to shape that soft tissue. So it's going to protect it so that the surgery site's healed, but then we have to shape it into the right form so that we can get it down into the socket of a prosthetic. The rigid is going to be one of the major ones. And again, we're going to want to reduce contractures. The #1 contracture patients are going to get are flexion contractures. I'm going to say this again. The #1 contracture a patient gets, whether it's an above knee or a below knee, is a flexion contracture. What do you think causes them to get a flexion contracture? What do you think they're doing in bed that's going to cause it? Yeah, they put a pillow under the residual limb. Yep. And now are they doing that maliciously? No. Right? They're doing it because it's comfort, right? And they don't think anything of it. And then you come in and yell at them. Just think about that. Before you go in and yell at them, say, hey, maybe the doc didn't clear this with you, but let me tell you why you don't want to do that. Right? I come from a perspective of educating the patient versus barking at them all the time. I only bark if I have to. So that means if that's the case, what position would be better for them to lay in post-op? In order to help prevent a flexion contracture. Prone would be, prone's the most ideal, right? If we can get them to lay prone post-op, that helps reduce that flexion contracture, right? Yeah, because gravity helps out. You're exactly right, because we pull kind of the hips forward and everything kind of gets straightened out, right? Now, if we do supine, we just have to make sure that they don't put anything under it, right? A lot of times with my patients that have amputations, I'll have them sit for about 10 to 15 minutes a day where their legs kind of dangling back off the side of the bed, their residual limb. So they get that like long, slow stretch going backwards. Does that make sense? As long as they have functional core control, obviously. If they don't have functional core control, we're not doing that. But we got to get them stretching so they get extension, because if this flexes up and gets stuck up here, the patient's not going to get into a prosthetic. Once we go from the post-op rigid, we're going to go to the IPOP, which is removable dressings and can be changed. These are where we start getting into shapers. And then they may get a temporary prosthetic, which is basically like, we have crutches in the hospital. They also have temporary prosthetics in the hospital that people have used before. Now they're sterilized, they're clean, blah, 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 but they just are not nice looking prosthetics. And it's just to get them to understand why it's important to shape their limb so they can start getting into one of these prosthetics. Shrinker fitting starts once we get the staples removed. Now we're really going to start getting it down, should have minimal, no drainage. The shrinker can be worn 24 hours a day, but must be taken off the shower. You don't want to get the shrinkers wet. It's just like, what was it? Gremlins. You don't want to get the shrinkers wet. They don't reproduce, but just don't get the shrinkers wet. And definitely don't feed your shrinker after midnight. All right, good. I got some. See, occasionally I can make you guys laugh. The main thing you want to watch with the shrinker is watch that it doesn't roll downward. Patient must possess the desire to ambulate in order to be qualified for prosthetics. If they don't want to walk and they're never going to walk, I'm never going to walk, I'm never going to use it, don't order a prosthetic. It's a waste. Put them in their wheelchair and let them gain 50 pounds. Just kidding. That was kind of wrong, but yeah, truthful. Incision area has to be healed and they have to have a script from the doctor. Once it's written by a doctor, the prosthetist has to come and evaluate the options for the patient. And again, this is usually where we come in because the doc's going to order the prosthetic. The PT is going to contact the prosthetist to get the prosthetic ordered. The prosthetist is going to come and the only person that's going to be there is you. This is an area you can really specialize. If you really like working with amputees, there's a huge market for this. Because the Amputee Coalition is always, and even if you just want to volunteer, right? The Amputee Coalition is always looking for volunteers to help out with patients that have amputations. I think it's the Las Vegas Amputee Coalition is what it's called. But yeah, so we're going to be in there helping that prosthetist, making sure that we can get the thing ordered. And then a lot of times I want to have the prosthetist there the first time we get them walking. So we want to make sure that that prosthetic works for gait. And so here's looking at a prosthetic and this person's actually golfing. I mean, come on. 40 years ago, 20 years ago, 30 years ago, this would not have been possible. Now they can pretty much live a normal lifestyle, right? With lower extremity kind of training, the first thing we have to do is make sure we teach them how to put the socket together. The socket is where the residual limb meets up with the prosthetic, right? It has to be an appropriate height. They have to have the process down of getting it in and out. The patient has to be observing for skin breakdown. There are going to be pressure tolerant and pressure sensitive areas. Pressure tolerant are where pressure is normal, right? So if I have a socket down, where I'm weight bearing down here on the bottom of my residual limb, that is going to be a pressure tolerant area. That's going to be a normal area. But where it kind of wraps around up in the top here, I'm going to have a pressure sensitive area where it can actually cause breakdown. When they assess, after they take their prosthetic off and they wait and watch it, any redness should disappear after 20 minutes. That's my good rule of thumb. So after 20 minutes, redness should disappear. If it doesn't, what does that possibly indicate? Could be infection, okay, yep. But on a pressure, yeah, pressure injury, right? Like that's what type of a pressure injury? If it doesn't return, doesn't blanch. What stage is it? That's a softball question, guys. Stage, non-blanchable pressure injury. I guess there's only 4 of them. Stage 1. Yeah, stage 1 is that non-blanchable erythema, right? Stage 2 is where we start getting an opening. If we have an opening, we're not paying attention. So this is a really, really good, this is from an old prosthetic books I have. That's why I kind of borrowed it. That's why they still call it a stump, right? This is an older book, but this really shows some really pressure sensitive areas on the knee when they get knee or knee prosthetics. And I know that we're not going to call them stumps anymore. It's residual limb, but this picture is really good at showing you what you're doing. I like this picture. I keep this picture in my clinical binder for when I'm working with patients with prosthetics, because I don't always think about all of those injury areas. And this helps me really kind of look at it from a perspective. Right? These are pressure tolerant areas. So these are areas where there's going to be normal pressure and should have normal redness. right? And that should go away. How quickly should the redness go away again? 20 minutes, good. So we're gonna have to work on the patient with proprioception through that residual limb. Tapping and vibration can be a really good way. So just tapping, right? And doing a little bit of vibration can be a good way of developing normalized sensation. Because a lot of times immediately post-op, they're hypersensitive. They have a little bit of hyperalgesia and the residual limb's really sensitive. So we have to start with a little bit of kind of normalizing sensation again, a little bit of tapping, maybe some cotton ball swiping to just get the sensations back to normal, because that way when they put that residual limb into the socket, it feels normal. Static and dynamic activities, are they able to stand what's called quiet? A quiet standing is without a lot of rocking or leaning side to side, right? This is really hard for kids to stand quiet, right? You tell the kids to stand still. What do? Right, they're all over the place. Well, yeah, fidgeting. A quiet standing with a patient with an ortho or a prosthetic is somebody that can stand in that prosthetic and there's not wiggle in the prosthetic, right? No fidgeting going on in that prosthetic. That means you have a really good solid fit. Can they walk in different terrains, right? We often train a patient how to walk in the hospital on a prosthetic, but we forget maybe that they're going to live up on Mount Charleston. Is Mount Charleston a totally different environment from walking in a hospital? Yeah, right. I had a patient once that, how many of you guys have ever been up to Mount Charleston? Right? If you go up to there where the actual little Mount Charleston, I don't know if it's a town or whatever that is, right? If you look at the driveways of most of those homes, what do they look like? Like vertical, almost. Yeah, they're steep. They're super steep, right? And so now I'm training a patient to walk on nice level ground, and he gets out of his truck because his wife drove him home, and he steps down and now realizes he's at like a 45-degree angle. Totally different thing, right? We may have to go and do some training with him around the house because it's a totally different world. Now he gets in the house, he's usually fine. Where I'm from, we had a lot of farmers and they were walking out in the fields to maybe feed cattle or feed pigs or stuff like that. Totally different world from walking in flat floors. We have to work with them. Are they able to handle a little bit of perturbations, a little moving around? Are they able to do single leg stance? Would you want a person who's got a prosthetic to do single leg stance? Would that be a good idea? And I'm talking single leg stance for extended periods of time, not just walking. Does that seem like a good idea? Yeah, too much pressure, right? So there is going to be a little bit of single leg stance right when they walk, but it should only be for a small amount of time. So we're not going to be doing a lot of single leg balance with them. Maybe if they're an athlete, we might, but your average Joe Blow, we don't have to do single leg stance with. Because all that's going to do is put all those pressure sensitive areas on stress. And then how do they develop prosthetic trust? Trust of that prosthetic is by repetition. The other thing is if you're working with the patient, just like we talked about with wheelchairs and spinal cord injuries and stuff like that, we have to practice falls. It is not if they are going to fall, it is when they are going to fall. And they have to know, how do they get up with that prosthetic? It's totally different. When we get back to school and we do the lab at the end of the semester, I'm going to put one of you guys in the what I call the prosthetic simulator, which is the leg or thing that we have for patients that can't bear weight on their ankles. I forget what that thing's called at the top of my head right now, but I'm going to put you on it and you're going to try to get up from the floor. It's not easy. So we need to be able to teach them how to get up from a Pain management, right? Do you think being on a lot of opiates is going to be good for patients that have prosthetics? No, right? Many reasons. Obviously, we know opiates not great, right? But they're not going to maybe then feel those pressure sensitive areas developing into pressure injuries, right? The other thing is opiates make you kind of dopey, right? We nopey because they make you dopey. So they may kind of be all over the place walking with that prosthetic. They may not put the prosthetic on fully wrong, right? I had one patient that was a patient that had severe alcoholism, and I came to see him, at home health, and he had his prosthetic completely backwards. He had his foot going backwards. And like he goes over to answer the door, and I can hear him like kind of slamming his foot down, walking over to answer the door. He's like, man, doc, I don't know why he called me a doc, but I remember he's like, man, doc, I don't think this prosthetic works. And I look down at it and the foot is backwards. Well, okay, let's talk about this, right? So those kind of things can happen. We've got to talk about flexibility. And again, main problem here, keep them out of flexion. And hip stabilization, we've really got to work on those hip muscles. So doing abduction, adduction, extension strengthening, and even a little bit of flexion strengthening for gait, but not a ton that we get contractures. We need to return to the prior level of function if we can, and then correct improper habits. What kind of stuff are they doing? What is their functional status? Are they going to be working in a casino? Because I had a couple here in town that got prosthetics and went right back to work in a casino. Can be challenging, right? For any of you guys that are servers in here or have been servers, imagine walking around with an above knee amputation delivering drinks. Right? I had a young lady that did that. She ended up with an above knee amputation from a car accident and wanted to go back to serving really bad. She really loved it. And she worked at one of the high-end clubs downtown. I can't remember what. And her big thing was, she was like, look, I know I get this prosthetic. I'm getting mad tips. And I kind of chuckled about it, but she's probably not wrong. Yeah. And so we worked on doing a lot of stuff that she would normally do. She worked in the club. So we worked on a lot of stuff, getting around people, carrying a tray while having that prosthetic. What are their goals, right? What are the components they have? The main thing is, what do they want to do? How can they go up and down stairs? Again, remember with stairs, you guys remember what that phrase is for going up and down stairs that I told you guys about? That helps remember which one you put up and which one you put down. You always ascend or go up with the good and down with the bad, right? Good goes to heaven, bad goes to hell. That's the way I always remember. And I tell my patients that a lot. And they're like, you said a bad word, but it sticks in their head, right? Which of the mnemonics stuck in your head? Was it the once one takes the anatomy, final very good vacations are heavenly, or the dirty ones? Yeah, the dirty ones, right? Of course. So that means that remembering the good goes to heaven, bad goes to hell sticks in their head, right? So if I've got an amputation on my right side, my left leg is going to ascend the stairs. My right leg is going to descend the stairs. Ramps and hills can be challenging, right? What if you don't have a ramp to practice on? How can you simulate a ramp? What could you do? So maybe you don't have any ramps to practice on. Get a piece of plywood, create one, right? Have them lean way far forward, pretend like they're on a ramp. There are things you can do. And then sit to stand training is big. How do they know how to get up and down if you don't train them? Functional transfers is important. How do they get up from the ground? We talked about mobility. When we are working with these patients, we need to work on forward and back, turning. We forget a lot about turning. Right? We forget about turning around. Somebody did that when we were talking about gait before. We forgot about teaching patients how to turn around. Braiding, where we cross the legs over. Running, maybe. What are their vocational activities? What are their specific hobbies, right? I'm a big role play game person. I like playing RPGs and tabletop RPGs, and I DM D&D a lot. Prosthetic has nothing to do with that. That's not something I have to worry about. But you've got somebody that's like a CrossFit junkie. Well, maybe you need to go with them to CrossFit and see what they do, see how you can make their prosthetics functional. Community outings are big. How do they get around grocery stores? I had one patient that I remember one year actually came to physical therapy and paid cash pay because he was going, it was a year that there was something really special happening on Black Friday. I forget what it was, but he paid to come, or she paid to come to physical therapy so she could be able to deal with the crowds during Black Friday. Paid cash pay for the PT. And so we simulated crowds pushing her around and stuff like that. And it's kind of cool, actually, but all that can happen. Gait training. Here's a question. You have a question on your board. You're teaching a patient with bilateral amputations how to begin gait training. Which is the most appropriate assistive device to use? What should you be looking at? Yep, that's it. Go down and look for parallel bars, right? You are training a patient that has a single amputation. Which is the most appropriate assistive device to use? Parallel bars, right? That's when you go down and you're like, yes, Mr. McKeever, I got this question. Which would be the most inappropriate, right? Which would be the least appropriate assistive device? What type of a cane specifically? Single point. Yeah, right? See how those two questions are varied, but they ask the same idea, right? Because both of them are going to have parallel bars somewhere in there. Both of them are going to have canes somewhere in there. One is which is the most appropriate, and one is which is the least appropriate. I don't like this guy here that's doing physical therapy right now. Why do you think I'm not happy with the way he's doing it? Yeah, it should be up with the patient, right? Now, I'm guessing this patient probably is a little bit further along, and what he's looking for is the actual prosthetic movement. So I guess I can get on it a little bit, but I think if I was this PT, I'd have a PTA, or if I was the PTA, I'd have a PT. There's no gait belt. Yeah, there's a lot wrong going on in this picture. Not to mention the shoes are kind of rainbow colored. So when we're walking with patients, we have to know what kind of stuff they have, how they're going to do it, and what their goals are, right? So we talked about the different types of disarticulations already. I'm not going to go through that again. Here's a patient with a total hip disarticulation and hemipelvectomy. This definitely does not look like it's fun, right? Look at how much that's going to work. And it's going to put all kinds of strain. You can see even their posture is not that great. And what kind of a crutch is she using? What's that crutch called again? Canadian crutch, pistol crutch, forearm crutch, anything like that, or loft strand. So I love this picture. I always keep this picture just because it's hilarious, right? Transfemoral, right? We've still got that. It's above the amputation. Talks about how the stump length will be. Didn't see the forearm, yeah. Right? This guy just looks too happy to have his prosthetic. Knee articulations where we go right through the knee. Again, we're going through these again. There's transtib prosthetic. Here's a patient that's got a rotational plasty. The removal of the femur and the tibia saves the lower limb and rotates it for a reattachment of the foot to the remaining limb. Whoa. Now, why would you do this? Well, think about it. Look at the surface I now have to put a prosthetic on. Yeah, you're looking at this going, oh, right? If I could do that, I've never actually seen that. I've only found pictures of it. I've never actually seen one in real life. It's still very strange. Grab my small foot. It's my strong foot. Symes disarticulation, we talked about the amputation of the foot. And I didn't get anyone with the small foot, darn it. Here's that hip socket. Here's the kind of manual lock and hinge kind of locks. You don't have to know specifics about these, but understand if you look at these, the more complex the knee joint, the more what? What do you think happens every time we make that knee joint more and more complex? More cursing. Okay, yeah, that too. But what happens to the price? Yeah, it goes up, right? Those leaf spring running prosthetics are not cheap. I mean, I haven't seen the price of them recently, but I think one of them's like 24 grand. It used to be, at least, right? For a good set of them. So here's where we talk about the trans-tib articulation. Here's those leaf springs. This one's a leaf spring that I'm talking about right here. Oops, why did my draw thing not come up? Right, that's a leaf spring. So there's patient trying it on. If you look at this, he's able to weight bear on it, but that's about all the weight bearing we want on a single leg stance. Going down and off curbs. So the initial assessment is going to be done by the PT, obviously, and then we're going to see them afterwards. PT has to set some really reasonable goals for us. Sometimes the PT sets unreasonable goals. If there's an unreasonable goal, talk to your PT about it. It's the only thing we can do. What's going to cause, what type of amputation they have? What's the cause? How long ago was it? The longer ago the amputation was, the harder it's going to be to get a prosthetic for it, because they probably didn't take care of the residual limb. Sometimes, if that's the case, the doc may go in and do another amputation to make it more compliable for prosthetics. When did they get their prosthetics, right? I saw one patient when I was down in Haiti for my trip that the guy had a Symes disarticulation, and he literally carved his own foot out of a tree or a chunk of wood and made his own little prosthetic. And when he came with that to the clinic, and we designed functional straps for him to put it on his foot. It's actually pretty cool. Like, yeah, that kind of stuff just, you know, when you think about it, we've got it easy here in this country, right? We need a fake foot. We can pretty much pull one off a shelf, right? But when you're in countries like that, when you maybe are either third world or not quite developed, a lot of times they have to do with what they got. Peg leg may be the only option, right? We all know that pirates are the favorite for people with peg legs because they love going to Arby's. So back to the type of prosthetic, or what kind of socket are they going to use? This is going to be a suction socket, right? Suction, exactly like it sounds. When they put that knee down in, it sucks in. And you usually hear it kind of sound like that. Does it have Velcro and lanyard? Meaning there are tons of straps that go with it. Is it a screw-in? Does the prosthetic have a little screw on the end of it that they can literally just screw their leg on? Those are a little bit more stable. Makes sense, right? It's kind of, that's a simple machine. The high fives are dealing with the socket. Is there osseointegration, meaning is there bone integration with the actual socket itself? What's the hip attachment? What kind of liners do we need? What kind of shrinkers do we need? Socks are the most important thing here when we're dealing with patients with prosthetics. The number one reason we have problems with patients with prosthetics is either have too many socks on or too little socks on. Even when we have an above knee amputation, that thing that we slip over their leg before they put it in a prosthetic is called a sock. So if they don't put enough on, doesn't work. If they put too many on, the socket may not work. So how many is too many socks? If the prosthetic no longer fits. Here's a suction, here's a lanyard style. Here's that hi-fi socket. There's a pin one. You can see that pin and screw coming out of the end of the prosthetic. There's a true screw one. Look at that, it goes right up into the leg. So outcomes assessment, the VR12 is kind of the most common assessment for it. And I don't remember what VR12 stands for off the top of my head, but I know it's a prosthetics assessment. The LEFS is another one, lower extremity functioning scale. And the main idea here with outcome assessments, we use whatever is useful. If it's not useful, get rid of it. Examine, I gotta correct that. No, bad, Mr. McKeever, bad. Examine the residual limb itself. I thought I caught all that. Mr. McKeever still has some bad habits, I guess. How's it healing? How's the muscle tissue? What do the scars look like? MMT, and I put this here, this debatable. And why I say that it's debatable is because when you cut off part of the muscle, are we actually getting a true assessment of that muscle? Yeah, no, right? So just because they only have a 4 out of 5 on the quad doesn't necessarily mean it's weak. It just means that it's not working the way it used to, right? So don't totally get stuck on, oh, they want to go to 3 out of 5. Well, you know, you try having your leg amputated and see if you've got a 5 out of 5. Just saying. The AMP Pro or No Pro are some predictors that can help us with this. Medicare usually requires these. These are just, again, forms to fill out to justify them needing this. Again, most times that's going to be filled out by the PT or by, not career services, that's for you guys. Social services, or what's the new term for whatever the new term, case management. There we go. So these are the K levels. Do you have to know these? No, but I put these in here in case you go to a clinic that deals with prosthetics. That way you have looking at the K levels, just talks about what's going to be their level for ambulation. Pavot's another one. So common gait deformities, hip hiking, circumduction, length stride, all this. We're actually going to look at a couple of videos quick tomorrow on this. So this is actually the perfect place to kind of stop for the day. So we're going to look at just a couple quick videos tomorrow morning when we get started that talk about what these different deviations look like. Because I have a bunch of videos saved that it's usually better, even when we're in the clinic or in the school, I can't demonstrate these things because I don't have a prosthetic. But I have a couple of videos that show each of these deviations, and it really kind of sinks home when you're looking at it, what these deviations look like. If they have a deviation, usually something's off with the prosthetic and we have to fix it. So we'll stop actually here because that was like the most perfect timing I could possibly ever have. I'll